समस्त को गुड आफ्टरनून जो मैंने जॉइन कर लेनी हमें 5 मिनट्स वेट करूछु हमर आउ किछि जण पैनलिस्ट और पार्टिसिपेंट्स मैंने जॉइन करिया पे जॉइन करला परे हम आरंभ करें।
हमारा ठीक है नाटा दे दिया सो
नमस्कार
नमस्कार एक्चुअली मु मोबाइल रो जॉइन कर एठी टेलीमेडिसिन रो कोन प्रॉब्लम होची चलिबो
ହଁ ଚଳିବ ଯେ କିନ୍ତୁ କାହିଁକି ଆପଣ ତ ଏଡେ ବଡ ପ୍ଲାଟଫର୍ମ ଥିଲା ଆପଣ ତାକୁ ୟୁଜ କରିଥାନ୍ତେ କଣ ଟେଲିମେଡିସିନ
ଆଜ୍ଞା
ଆମେ ତାକୁ ଷ୍ଟ୍ରେନ୍ଥେନ କରିବା କଥା
ହଁ
ଚାଲୁ।
ନାଇଁ ଟେଲିମେଡିସିନ ରୁ କଲୁ ଯେ ଟିକେ କଣ ଟ୍ରବୁଲ ହଉଛି ଜମା ହଉନି ସେ କଣ ଅଭିଳାଷ ବାବୁଙ୍କୁ ମାଗିଲେ ପୁଣି ଅଭିଳାଷ ବାବୁ ଆଉ ଗୋଟେ ଲିଙ୍କ ଦେଲେ ସେଇଟା ବି କାହିଁ ଖୋଲୁନି କାରଣ ମୋର ଏଇ ମୋବାଇଲରେ ଯୋଉ ଜୁମ୍ ଅଛି ସେଇଟା ଏଇଠୁ ବି ସେୟାର କଲେ ହବ।
ମୋବାଇଲରେ କେମିତି ସେୟାର କରିବେ ସାର୍ ଆମେ ଏଇଠୁ କରିବୁ
କଣ କହିଲେ
ମୋବାଇଲରେ କେମିତି ସେୟାର କରିବେ?
ସେୟାର ସ୍କ୍ରିନ୍ ନହେଲେ ସେଇଠୁ ପୋଷ୍ଟିଂ କରିବେ ମୁଁ
ପଠାନ୍ତୁ ତାହେଲେ
सेम प्रेजेंटेशन ଟା ଅଛି ଯଦି
ସେମ୍
ଆପଣ
ନାହିଁ ସେମ୍ ଅଛି ନାଇଁ ତ ଆପଣ ଚେଞ୍ଜ କରିଥିବେ ନା।
ମୁଁ ଦେଖୁଛି ସେୟାର କରୁଛି ହଉଛି ନା ନାଇଁ ମୋ ସ୍କ୍ରିନ୍ ଗୋଟେ କରୁଛି ଜଷ୍ଟ ଟ୍ରାଏ
ହଉ
ଟ୍ରାଏ ଫାଷ୍ଟ ତମକୁ ପିପିଟା ସରିଗଲାଣି Is it visible?
ସ୍କ୍ରିନ୍ ଟା ଟିକେ ବଡ କରିହବ?
ହଁ ବଡ କରି ହବ
ହଁ ହେଇଗଲା ତ। ହଁ
ଏଇଟା ଚଳିବ
ହଁ ହଁ ଚଳିବ କାଇଁ ଦୌଡ଼ିବ ସାର୍।
ଆଜ୍ଞା ଠିକ ଅଛି ତାହେଲେ ଏବେ ବଡ ହେଲା ଠିକ ଫୁଲ ଦିଶୁଛି।
ହୁଁ ନମସ୍କାର ପ୍ରଭାକର।
ସାର୍ ନମସ୍କାର ଜୁମ୍ ଟା ଟିକେ କଣ କାମ କରୁନି ପ୍ରୋବ୍ଲେମ ହଉଛି ଆଇ ଡୋଣ୍ଟ ନୋ ହ୍ୱାଇ ତେଣୁ ଏଇଟାରୁ
ଏବେ
ନହେଲେ
ଠିକ ଅଛି ତ?
କହିଦେବି
ଦିସ୍ ଓକେ।
ଆଜ୍ଞା ଆଜ୍ଞା ସାର୍ ଥ୍ୟାଙ୍କ ୟୁ ସାର୍ ଆଉ ଆଦିତ୍ୟ ବାବୁ କଣ କହୁଛନ୍ତି ଆମର ସେଠୁ ସେଣ୍ଟରରେ କ୍ଲିୟରାନ୍ସ ଦରକାର
ହଁ ସାର୍ ଠିକ ଅଛି ସାର୍ ସ୍କ୍ରିନ୍ ସେୟାର
ଠିକ
ହଉଛି
ଅଛି
ହଁ
ଆଜ୍ଞା
ସାର୍
ଆପଣ
ଆଚ୍ଛା ହଉ
ଆଇଟି
ତାହେଲେ
ଏକ୍ସପର୍ଟ ଅଛନ୍ତି ଆଉ।
ତାହେଲେ ଠିକ ଅଛି ମୁଁ ତାହେଲେ ଦେଖୁଛି ଏମିତି ରଖିବା ଗୋଟେ ମୁଁ ଷ୍ଟାଣ୍ଡ ଦିଅ ଫ୍ରାନ୍ସିସ୍କୁ ନବ
ଟପ୍ ସେୟାର କରିଦିଅନ୍ତୁ ସାର୍।
ଆଜ୍ଞା ଷ୍ଟପ୍ ସେୟାର କରୁଛି ଆଜ୍ଞା ଠିକ
ହୁଁ
ଆଜ୍ଞା
ଏ ଲିଙ୍କ ଟା ଆକ୍ଚୁଆଲି ଖୋଲୁନି ଆଉ ଗୋଟେ ଲିଙ୍କ
ଆଜ୍ଞା
ପଠେଇଥିଲି ସେଟା ଖୋଲୁଛି।
ମୋବାଇଲ କଣ୍ଟାକ୍ଟ ଅଛି
ଶହେ 14-15 ହେଇଗଲାଣି ଷ୍ଟାର୍ଟ କରିହବ।
ହଁ ସାର୍ ଟିକେ ସାର୍ ଯାଇଛନ୍ତି ମ୍ୟାଡମଙ୍କ ସହିତ କଥା ହେବା ପାଇଁ ଡାଇରେକ୍ଟର ମ୍ୟାଡମଙ୍କୁ ଡାକିବା ପାଇଁ
ଆଉ ମ୍ୟାଡାମ ଆସିନାହାନ୍ତି ନା କଣ?
Good afternoon. Respected IEP, our nodal officer COE Professor Prabhakar Mishra. Amar Ram Kumar sir join karibe shortly, and other dignitaries present here. Director of Family Welfare will shortly join in our VC. Till then, खाली introduction दवा में हमें आज ये जो करूचे समस्त जानी थी वे मैडम सर टिके म्यूट कर देता हूँ तो समस्त हमें जानी थी वा नेशनल न्यूबॉर्न वीक हमें विगत 6 दिन धरि पालन कर सारे एक्चुअली वर्तमान रो स्टेटस हमरो ओडिशा कॉन्टेक्स्ट जदि हम कहबा हमें सेकंड हाईएस्ट इन द कंट्री इन नियोनाटल मोर्टालिटी एवं जेते बेले हमें अंडर 5 डेथ को देखुचे तादरु 60% पाखा पाखी हे जाउची नियोनाटल डेथ एवं जेते बेले आईएमआर देखुचे सेठु 75% पर्यंत नियोनाटल मोर्टालिटी होची एवं डिस्ट्रिक्ट अगेन डिफरेंट डिस्ट्रिक्ट रे वेरीज तेणु हमें याको एड्रेस करिवा पई बहुत छोट छोट जिंस ऊपर हमें गुरुत्व देवा पई कहया जाउची जेमति कि जीरो सेपरेशन देन डू नो हार्म टू द बेबी ए सब जिंस को आखि आगे रखिकी समस्त बर्तमान सचेतन करियो पड़छि जे आमे न्यूबॉर्न मानकर जत्न केमति नबा एवं तांको केमति तांकर सर्वाइवल बढ़ेबा तो बहुत छोट इंटरवेंशन रे आमे ता करि परिबा जेमिति कि वर्तमान रो कांसेप्ट अनुसार delayed cord clamping then early initiation of the breastfeeding exclusive breastfeeding then keeping the baby warm then sanitation and hygiene all these things are has a great role in survival of the newborn तो एथि पे हमरो स्टेट रो समस्त स्टॉलवर्ड्स एथरे भाग होचंती मु बहुत धन्यवाद देबी हमरो प्रेसिडेंट आईपी इंटरेस्ट नै करी विजय सर ये सब प्रोग्राम इन्वॉल्व होचंती एवं सब पेडियाट्रिशियन मान को मोटिवेट करचंती जे हमें केमति स्टैंडर्ड ट्रीटमेंट गाइडलाइन फॉलो करबा 2010 मसिया तळे जदि देखला पूर्वरु कोनोसी एसएनसीयू स्टेट रे नथिला वर्तमान 44 एसएनसीयू फंक्शनल आमे न्यूबॉर्न स्टेबलाइजेशन यूनिट मध्ये 62 टी फंक्शनल करिचे एवं सेठी हमर पेडियाट्रिशियन माने जो माने अछंती स्टेट रे से माने कार्यरत एवं क्वालिटी इंप्रूवमेंट मध्ये धीरे धीरे विभिन्न फैसिलिटी रे होउची आगुरु आमे 78% डिस्चार्ज रेट करथिले एवं वर्तमान एटा बढ़ी के 83% हेला तथापि हमको आहुरी आगु जिबार अछि तो सही उद्देश्य रे हमें VC करूचे टू मेक यू अवेयर अबाउट डिफरेंट स्टैंडर्ड ट्रीटमेंट गाइडलाइंस वर्तमान आम संगे मैडम डायरेक्टर फैमिली वेलफेयर डॉक्टर संयुक्ता साहू जॉइन करचंदी एवं मैडम कर लीडरशिप रे ओडिसा रे हमें न्यूबॉर्न केयर को बहुत सीरियसली हमें नै जो एवं ए 6 दिन जाक जो न्यूबॉर्न केयर वीक गला हमें 6 दिन जाक प्राय सब दिन हमर किछि किछि एक्टिविटी हमें करिछु एवं सब बेले माने इन्वॉल्व होबे करे पे चाहिछु सब स्टेट डिस्ट्रिक्ट रो आ पेरिफेरी रो जते स्टाफ अछन समस्त को इन्वॉल्व करे पे चाहिछु तो ई परिप्रेक्षी रे मु मैडम को कहबी टिके इनागुरल एड्रेस देबे एवं तापरे हम एक्सपर्ट्स मान को पाख को जिबा टू लिसन रिगार्डिंग द न्यूबॉर्न केयर मैडम प्लीज
समस्त को मोर नमस्कार नेशनल न्यूबॉर्न केयर वीक उपलक्षे हमें स्टेट तरफ रु आज वर्चुअल ओरिएंटेशन प्रोग्राम करिछु सर्विस प्रोवाइडर प्रोग्राम ऑफिसर एवं प्रोग्राम मैनेजर मानकर जोटा पई हमको इंडियन एसोसिएशन ऑफ पेडियाट्रिक्स हमको सपोर्ट करूची एवं नेशनल नियोनाटोलॉजी फोरम से भी सपोर्ट करूची एवं तांको सपोर्ट रे आपण माने जानि थिबे देखि थिबे भी सार को डॉक्टर भैया को हमर डॉक्टर प्रभाकर मिश्रा सर को एंड डॉक्टर राम कुमार हम सारे जॉइन करिवे तेणु से माने हमर मास्टर ट्रेनर हिसाब रे बहुत बढ़िया ट्रेनिंग प्रोग्राम रे जॉइन करिसंती एवं आपण मान को ट्रेनिंग मध्ये देइसंती डॉक्टर मिश्रा गर त इंट्रोडक्शन दरकार नै भास्टली एक्सपीरियंस प्रोफेसर रे अछंती Professor and Dean of Amara Sardar Vallabhbhai Patel Institute of Pediatrics जोटा कटक रे अछि तार अछंदी एवं सार हमको सब बेले सपोर्ट करी आछंदी तांका लीडरशिप रे हमें अगणित ट्रेनिंग प्रोग्राम डिस्ट्रिक्ट रो करि सारलुनी एवं आपण माने समस्त ए प्रोग्राम रे उपकृत होचंदी तांकर ट्रेनिंग माध्यम रे एवं डॉक्टर भुइया जे हम संगे अछंदी भुइया सर प्रेसिडेंट अछंदी इंडियन एसोसिएशन ऑफ पीडियाट्रिक ओडिशा चैप्टर रो सार भी हम संगे सब मीटिंग रे जॉइन करिसंती एवं दिग्दर्शन देउछंती आज हमर जो टॉपिक अछि ए वीक रो नेशनल न्यूबॉर्न केयर वीक रो जे रेशनल यूज ऑफ एंटीबायोटिक में करिबा एवं एंटीबायोटिक रेजिस्टेंस जोटा हमर देखा जाउची ताकू केमती प्रिवेंट करिबा हमर जो केयर अछि हेल्थ केयर इंस्टीट्यूशन ले जो हमर सब यूनिट्स अछि एनबीएसयू एसएनसीयू हमर न्यूबॉर्न केयर यूनिट जते अछि सेठी फ्रॉम द बर्थ ऑफ द बेबी before the birth of the baby I should say before the birth of the baby to discharge and after discharge at home तेणु जन्म हेबा पूर्वरु बेबी रो मदर रो केयर नबा केमिति एवं ता परे बेबी रो डिलीवरी हबो केमिति असेप्टिक कंडीशन ने केमिति हमें वार्ड रे बेबी रहिबो केमिति कंगारू मदर केयर एंड एक्सक्लूसिव ब्रेस्ट फीडिंग एदिटा हम इंप्लीमेंट करिबा करि बेबी रो रेजिस्टेंस बढ़ेबा एवं सब सेंटर लेवल पर्यंत आमे यदि कोनोसी बेबी रो किछि प्रॉब्लम हे तार केमिति केयर नबा एवं हमर प्रोग्राम सेटिंग कोन रहिछि ता ऊपर आज हमको प्रोफेसर मिश्रा एंड डॉक्टर भुइया एंड डॉक्टर टीवी राजकुमार हमारा राम कुमार हमको ट्रेनिंग देबे आपण माने निश्चय एटा बहुत आपनको पे उपादेय साब्यस्त हो एवं आपण माने धीरे धीरे ए ट्रेनिंग रे पार्टिसिपेट करिवे एति कि आपण को रिक्वेस्ट निजर अलगा डाइवर्सन यदि अछि ताकू दूर रे रहंतु एवं चैट बॉक्स को जाइकरी आपनकर जहा अछि क्वेश्चन ताकू पुट करबे ताकू देबे लेखि कि देबे एवं नहले एंड ऑफ द प्रेजेंटेशन आपण हाथ उठेबे हमें आपनको क्वेश्चन पचरिबो आपण क्वेश्चन ता आपनकर डाउट क्लियर हे परिबो किंतु दया करी मझी रे आपण इंटरप्ट करिवे नै एवं धीरे धीरे ट्रेनिंग कंप्लीट करिया को देबे थैंक यू
इन द मीन टाइम मु यूनिसेफ को मध्यम बहुत धन्यवाद देवी मीना मैडम को
बिना इज सॉरी दिस आई एम सॉरी रियली सॉरी
से भी लिंक देइचंदी एवं तांकर सहाय्य रे हमें एई वर्चुअल क्लास करि परछे एवं आगु मध्य तांकर सपोर्ट जारी रहइबो स्टॉप करबो ना सार थैंक शेयर कर
से एटा जॉब करबे तो शेयर खाली करबे स्क्रीन शेयरिंग कर दो वेलकम मीना मैम
अच्छा प्रभाकर सर now the platform is yours and your topic is number 1 first so can you share the slides Professor Mishra
I'm muted in anti
Okay. Good afternoon. So I am doing the screen share from this side. Okay. ताकू ଟିକେ कम कर दी लो
बहुत करो हां
सेट हो बंद share तो is my screen visible?
हां सर देखा जाउची
Okay. हाँ सेट लगा So good afternoon everybody, all the respected faculties, our Madam revered Madam Dr. Sahu, our Director of Family Welfare, then our representative from UNICEF, who are the main organizers of this workshop webinar, So, and all the other faculties, our president of IAP state branch, Professor Dr. B.K. Bhuya, and all the distinguished Dr. T.V. Ramkumar, and all other faculties, and all the delegates watching this show. So, should I tell in Oriya and English both? Is it convenient? Hello.
ଆରେ ବେଶୀ ଓଡିଆରେ କୁହନ୍ତୁ ଇଂଲିଶ
हाँ
କମ
बेस ओडिया अच्छा ठीक अछि so as you know the newborns are susceptible to infection नवजात शिशुटी जन्म ହେଲା ପରେ बहुत रोग संक्रमणର ଅସୁବିଧାରେ ପଡିଥାଏ ସେ ରୋଗ ସଂକ୍ରମଣ ରୋକିବା ପାଇଁ ଗୁରୁ ଦାୟିତ୍ୱ ରହୁଛି जो माने स्वास्थ्य सेवारे अछंती डाक्तर हो बा नर्सिंग ऑफिसर हो बा आपनकर जो एनवायरनमेंट हो डिलीवरी रूम हो आउ आपनकर जो पिलाटी को जोठी जत्न निया जाय न्यूबॉर्न कॉर्नर आउ जोठी एसएनसीयू विभिन्न बा एनबीएसयू जोठी ताकू केयर करा जाय सेठी पिलाटी पूरा स्टेराइल एनवायरनमेंट रे मा पेट रे थाए तेणु आम मान को प्रत्येक स्टेप रे जदि सावधान हवा ताहले ही हमर कंट्रोल हे परिबो आउ ये गुडा कहउछन हॉस्पिटल एक्वायर्ड इन्फेक्शन बा नोजोकोमियल सेप्सिस हमर डाक्तरखाना से जीवाणु देई थाए कारण पिला स्टेराइल एनवायरनमेंट रो बाहर थाए तेणु आमर सब जिनस पत्र आम जिते जहाँ व्यवहार करूँ जदि सावधान हवा ताहले आमे ताकू से गुड़िक प्रतिरोध करिपरिबा आउ थरे नवजात शिशुटी जदि प्रीमाच्योर पर्टिकुलर होता है बा कम ओजन रहता है ताहले ताकू ए रोग संक्रमण शक्ति तार न थाए कहया गले बहुत कम थाए तेणु ताकू रक्षा करिया हेले ए रोग संक्रमण रु हमकू सब प्रकार ध्यान देवा पड़िबो आ सब प्रकार प्रिकॉशन नवा पड़िबो जेमति कि शिशुटी सुस्थ होई बढ़िबो आ ताकू संक्रमण हेबो नाही तेणु सेथि पई थरे ताकू संक्रमण हेले तार कोन हुए ना आमे जेतबे ताकू कोनसी गोटे टेस्ट करचू ताकू टिके पंक्चर करचू ताकू वेन रे सलाइन दउचू सेही बाटे जीवाणु गुडी पसि जानती सेगुडा पसि गला परे रक्त रे इन्फेक्शन हे जाय ब्लड स्ट्रीम इन्फेक्शन सेगुडा हे गला परे तांकर जेहेतु रेजिस्टेंस टू इन्फेक्शन बा रोग प्रतिरोध शक्ति कम थाए तांकू सेप्सिस हो जाए जोटा कि आमे नियोनाटल सेप्सिस बा नवजात शिशुर संक्रमण कहिताउ से सेप्सिसटा सेमानकर ब्लड ब्रेन बैरियर भी नाही तेणु बेले बेले सेटा निमोनिया को गति करे बेले बेले सेटा ब्लड ब्रेन बैरियर नथिबा जोगु मेनिंजाइटिस होई जाए आ जोगुडा को अति मारात्मक रोग होइथाय ताकू ट्रीटमेंट मध्ये बहुत दिन लागि थाए 7 रु 14 दिन लागि थाए निमोनिया ट्रीटमेंट आउ मेनिंजाइटिस हे गले 14 रु 21 दिन भी देबाकू पड़े वेन रे ट्रीटमेंट सेमान को ओराल औषध देई हुए नाही तेणु आईवी देई रखिया पड़े तेणु प्रत्येक स्थल रे जेतेबेले आमे पिला को हैंडल करछे पिला को कोनसी प्रोसीजर करछे हमको सावधान हबाकू पड़िबो तेणु हमको एंट्री पॉइंट रे चेक करिया पड़िबो जेमति रोग जीवाणु एंट्री करिवो नाही पिला को आमे जेतेबेले पिलाटी को नेकरी स्पेशल न्यूबॉर्न केयर यूनिट रे रखुचे हमको समस्त को सावधान हबाकू पड़िबो आ से ऑर्गेनिज्म जेमति प्रोलिफरेट करिवोनी वंश वृद्धि करिवोनी सेटा को देखिया पड़िबो आ बेबी टू बेबी केमति स्प्रेड करिवोनी बेले बेले कोन हुए आपनकर एसेंसी रे प्रति बेड रे गोटिए स्टेथर या कथा है प्रति बेड रे थर्मोमीटर अलगा रहबा दरकार प्रति बेड रे स्वाब अलगा रहबा दरकार जदि आपण गोटिए स्टेथर रे सब पिल्ला को एग्जामिन करिवे ताले गोटे इन्फेक्टेड बेबी रो जीवाणु जाई करी गोटे सुस्थ बेबी देहरे लागि जिवो सेति पई प्रति शिफ्ट रे सेही स्टेथोस्कोप को आपण को स्टेरिलाइज करी टंगेबा को पड़िबो आ से भले हला मेजरिंग टेप आपण मुंड मापुछंती पिलार मुंड मापिला बेले आपण पिला जदि गोटिए टेप यूज करिवे से संक्रमण हो प्रत्येक पिलार बेड पाखे ताको अलग अलग रखा दरकार आउ गोटे जिनस आपनकर जेतबेले कोनसी टेस्ट करछन तार ग्लूकोज ग्लूकोमीटर रे ग्लूकोज देखुछंती हेल्थ फ्री करछन सेठी जदि प्रिकॉशन न नेबे सेतबेले मध्ये जीवाणु प्रवेश करिवो आउ सेथि पई हम मानकू प्रत्येक स्टेप रे प्रत्येक डाक्टर हो प्रत्येक नर्स हो नर्सिंग अफिसर मेडिकल अफिसर टू आरंभ करी जेते इन्वॉल्व होछंती इन द केयर ऑफ द न्यूबॉर्न बेबी इन न्यूबॉर्न एरिया सेमानंकु सबु एक्सट्रीमली सावधान होगा पड़िबो आउ कोन कोन करिया पड़िबो से विषय आलोचना करिबा तेणु प्रिवेंट एंट्री ऑफ माइक्रो हमको समस्त को क्लीन डिलीवरी करिया पड़िबो क्लीन रिससिटेशन करिया पड़िबो रिससिटेशन रे जहा जहा यूज करा जाउची आपनकर स्टार्टिंग फ्रॉम आम्बू बैग हला बा लैरिंगोस्कोप हला बा सक्शन हला सबु जिंस गुडा को प्रॉपर्ली स्टेरिलाइज हे जदी रहितिबो ताहले जाईकरी सेटा हमें करि परिबा आमको समस्त को एनवायरनमेंट को क्लीन रखा पड़ो सरफेस क्लीन रहिबो प्रत्येक लोक हाथ धोईकरी एसेंसी भितर को पशिबे भितर पशिला पर भी आउ थरे हाथ धोइबे प्रत्येक बेबी ठु आ गोटे बेबी गला बेले इन बिटवीन हैंड रब करिया पड़िबो आउ आपनकर गाउन और स्लीपर सब अलग हम आउ हैंड वाशिंग फैसिलिटी विथ डेमो आपनकर रहिबो आउ प्रत्येक लोक जो माने एसेंशियल एरिया रे काम करछन न्यूबॉर्न एरिया रे से माने नख काटिबे से माने 2 दिन खरे नख ट्रिम करिवे से माने केबेले ए चूड़ी मुदी एउडा पिंदिकरी आसीबे घंटा तेणु क्लीन रहिबो एल्बो जाय हाथ धोइबे जोड़ा गाइडलाइन अछि हाथ हैंड वाशिंग टेक्निक धोइकरी तापरे आपण पिला को टच करिवे तापरे आ गोटे जिंस हला मोबाइल फोन रो सरफेस रे एते जीवाणु थांती जोटा कि आपनकर पायखानार पैन सहित समान तेणु आपण ताकू भी दूरे रखले भलो न्यूबॉर्न केयर एरिया को आउ ए सब जिंस प्लस एयर चेंज बेले बेले द इन्फेक्टेड एयर रहउची ताकू जदी चेंज करिवे सेटा हेइ परिबो जोटा कि हमर बेले बेले हम इन्वेस्टिगेशन करू सलाइन तयारी करू आईवी फ्लूइड तयारी करू ताकू लैमिनार फ्लो तळे सेहि सका से रखी तयारी करा जाए सो आपनकर निकु जोटा हला न्यूबॉर्न इंटेंसिव केयर यूनिट सेटा एम्ति जगह हवा दरकार जोटा कि डिलीवरी रूम रो पाखो थिबो as near and as close to the labor room area and it should be away from septic area कहना रोग जीवाणु संक्रमण हबो so always from other intensive care unit it should be away from PICU area also and controlled access and controlled environment is very important सेति आपण को एयर कंडीशन करिया पड़ो एयर कंडीशन फिल्टर को प्रति 7 दिन बा 15 दिन थरे सफा करिया पड़ो आउ दरकार पड़ले एयर फिल्टर आपण यूज करि परिबे बा डिह्यूमिडिफायर यूज करि परिबे ना ट्रैफिक टू अदर एरियाज नॉट टू पास थ्रू एसएनसीयू तेणु एसएनसीयू एमि जगह हबो ता दैट शुड नॉट बी ऑन द वे टू अदर वार्ड्स और अदर एरियाज टू प्रिवेंट इन्फेक्शन देन वॉश बेसिन एंट्री रहिबा मस्ट एटा बहुत चौड़ा हबो जेमति कि आपनकर एप्रोप्रिएट स्लोप रहिबो सिंक रे आउ सील्ड वॉल रहिबो अराउंड द सिंक रहिबो नले सेठी छोटो पोको सरपा रहिबे पिंपुडी रहिबे जंदा रहिबे सब प्रॉब्लम करिवे तेणु आपन को सब क्लीन रखिया पड़िबो तापरे लिक्विड सोप फैसिलिटी रहिबो हैंड ड्राइंग पई भी फैसिलिटी रहिबो ट्रैश बिन्स अलोंग द सिंक रहिबो आउ कोन सी जगह रे लीक करनथियो सेटा परफेक्टली चेक होइतो टाइम टू टाइम आउ preferably to use RO water RO plant water because non contaminated water is also important and warm and cold weather रे आपण से अनुसार कंट्रोल करी ताकू यूज करिवे पानी रखिवे बेसिन पई तेणु वाश बेसिन रो ए भलिया हबा दरकार आइडियल वाश बेसिन जोटा कि आपनकर क्रिप्स विशेष किछि नथिबो आ सेउडा जहा पानी पड़ला पळै जिवो आ जमा ही रहइबनी बा स्मेल बारिबनी ए सब पिक्चर देखैछि केमति आपण हाथ धोइबा एरिया कोन हबा दरकार केमति हैंड ड्रायर रहइबा दरकार आ ट्रैश बिन रहइबा दरकार दैट शुड बी रेस्ट्रिक्टेड एक्सेस एंड एंटी रूम बिफोर एंट्री सेगुडा भी रहइबा दरकार एमति आइडियल करा जिबा दरकार आजिकल भी हमर एमति बहुत जगह रे आरंभ हलान आ आपण पूरा हाथ धोइबे एल्बो जाय हाथ धोइग्री जिबे हैंड वाशिंग इज ए वेरी इंपोर्टेंट इन प्रिवेंशन ऑफ इन्फेक्शन कहवा करथा हला हाथ धोइबाटा परफेक्ट भाबरे करिबा दरकार आउ आपनकर हला न्यूबॉर्न रो बेबी आजिकल करा होची फैमिली सेंटर्ड केयर चित्रे एठी आपण रखिबे जेमति सफिशिएंट एरिया रखिबे फॉर सिटिंग ऑफ द मदर को भी कंफर्ट दरकार से भाबिबो जेमति निज घरे अछि आउ तार जहा एक्सेसरीज दरकार पिला पई तो तार बेड रहिबो किंतु मां पई भी जहा दरकार से ता पाखर रहिले आपण हैंड वाशिंग पई फैसिलिटी रहइबा दरकार बेबी पई बेबी कट रहइबा दरकार ओपन केयर सिस्टम आउ एग्जामिनेशन टेबल रहइबा दरकार प्लस मां पई भी सुविधा पई दरकार एंड आल्सो तार डेली नीड मीट करिया पई बाथरूम एंड तार वॉशरूम से सब ठीक दरकार ताकू भी सफा सुतरा मेंटेन करियार आवश्यकता रहिछि एंड नो वन क्लीन्स द मोबाइल फोन बिफोर एंट्री तेणु मोबाइल फोन को आइडियली क्लीन करिया कथा नियरली 70% फोन सार कंटामिनेटेड आउ कॉमन ऑर्गेनिज्म जहां फोन रे थांदी से माने डेंजरस ऑर्गेनिज्म कोन ऑर्गेनिज्म सेगुडी को हला आपनकर सिडोमोनास स्टाफिलोकोकस से सब ऑर्गेनिज्म आ सेगुडा को अति मारात्मक जीवाणु ट्रीटमेंट करिया भी भारी कष्ट थरे स्टाफिलोकोकस जदी नवजात शिशुर भीतर को पसिला ताले से करिवो सेप्टिक आर्थराइटिस ओस्टियोमाइलाइटिस हाड़ पाची जीवो खंजा पाची जीवो मेनिंजाइटिस आउ मेटास्टैटिक एब्सेसेस आउ से स्टाफिलोकोकस जीवाणु को ट्रीटमेंट करिया को 4 रु 6 सप्ताह पेरेंटल एंटीबायोटिक दबा को पड़ी थाए आउ डेला सिडोमोनास ऑर्गेनिज्म भारी रेजिस्टेंट से माने ड्रग रेजिस्टेंट मल्टी ड्रग रेजिस्टेंट होंती आउ ट्रीटमेंट करिया भारी कष्ट होई पड़े आ बेले बेले सेटा शिशुर जीवन हानि करि थाए आ गोटे हला प्रिवेंट प्रोलिफरेशन हमर इंफ्रास्ट्रक्चर हाउसकीपिंग एमती हबो जेमती कि जीवाणु कौनसी जगह रे ग्रो करि परिबे नाही सेथिबाई हमकु कोन करिया पड़ियो स्पेसिंग करिया पड़ियो इन बिटवीन बेड एयर टर्नओवर करिया पड़ियो आ वेट एरिया को सब बेले ड्राई करिया पड़ियो वेस्ट मैनेजमेंट परफेक्टली हबो विथ लेवलिंग and charts everywhere and everybody entering into the newborn care area should be trained about the waste management and the drug and medications preparations area ideally to newborn मानकर lamellar flow under कले आपण बैक्टीरिया जीवाणु रो मुक्त होई परिबे आउ डाक्टर एवं हमर नर्सिंग अफसर माने वर्क स्टेशन रे से माने से भीतर किछि खाया पीवा करिवे नाही से भीतर कोनोसी खाद्य पसियो नाही फाइल्स एंड रिपोर्ट्स रे भी जीवाणु आस्तांती तेणु ताकू दूरे की रखिबो दरकार आउ आपनकर स्पेस फॉर निकू बेड एडिक्वेट स्पेस रहिबो तार डिस्टेंस बिटवीन टू बेड्स ठीक रे 2.4 मीटर मेंटेन हबो एंड स्पेस होची 11.2 स्क्वायर मीटर हवा दरकार मैक्सिमम डिस्टेंस फ्रॉम सिंक हवा का दरकार 6 मीटर एंड मिनिमम डिस्टेंस अवे फ्रॉम सिंक इज 90 सेंटीमीटर फ्लोर शुड बी क्लीनेबल and no crevices or penetrations and it should be in wood or rubber so walls and ceiling should be washable and clean so this is an ideal area where you can move the instruments like the open care system and trolley and everything and it can be clean in a single go by the person who is concerned with the floor management. Then the temperature should be between 22 to 26 degree and humidity should be 30 to 60%. Air change should be 6 with 2 fresh and filter should be HEPA filter is ideal and RO water is ideal. Cold and warm should be available.
that कटिगला बोधे
हाँ टिके कोन गोटे कॉल आसी कटिगला करूची करूची कोन हल्ला नेट काय कटे नेट भी अनस्टेबल बोधे होची टिके
हमें एटू शेयर करू सर
हाँ करना कर दियंतु बेटर हबो कर दियंतु
ଆପଣ stop sharing କରିଦିଅନ୍ତୁ ରତନ ମିଶ୍ର।
हाँ मु स्टॉप कर दूची ताले फोटो कर देले सेटा हे जीवो ठीक ओके ओके हाँ
ସ୍କ୍ରିନ୍ ଟିକେ ବଡ କରନ୍ତୁ। ହଁ ଠିକ ଅଛି।
सर देखि पाछनी
हाँ हाँ देखु दिसची विजिबल
ओके स्टेप 3 रे अछि
ठीक एटा 3 रे अछि ना ओके ओके ठीक 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 so most important is hand hygiene so you must thoroughly wash your hand as per the steps and the chart should be there in front of the basin and you will have to use the disposables and it should be hygienic and properly sterilized and whatever is available that should not be soiled then you nurse patient ratio should be maintained whatever is important and this is the chart the how to do hand washing various steps are shown how to clean and everything is trained in that so we'll have to cut the nails and remove all the bangles watch and everything and you should thoroughly wash using free flow of water, and you must dry it, and then go to the to examine the patient and to take care of the patient. Next. So this is the 5 moments are shown here. What moments to do and how to do. Very good videos are there. So this can be shared in the newborn care group, and anybody will follow that. Next. So this is the, yes. So these are the hand washing technique. How to show that, how to do that. Everybody should follow these things. And you must cut the nails. There should not be no nail polish on the nail, because these are chemicals and they are harmful. So they should be removed while working in these areas. Okay, next. So this is the nurse-patient ratio. This is shown that nurse-patient ratio per shift should be 1 nurse for 3 to 4 newborns. So that is the recommended. In continuing area, in intermediate area, it should be 1 nurse for 2 to 3 newborn. Intensive care area, it is 1 nurse to 1 to 2 newborn. So that in intensive care area is our NICU area. So it is around 1 to 1 roughly. And in other areas, it can be 1 to 2 or 1 to 3. Multi-system support also like that. So in isolation room, the presence, the room should be separate, and तारो रहिबा दरकार, तारो entrance रे sink रहिबा दरकार, skin with auto system रहिबा दरकार, ये and place for wearing gown clean and soiled item ପାଇଁ रहिबा दरकार. Then negative pressure air with 100% exhaust should be, so that all infected material can be thrown out. Then device to monitor air pressure should be रहिबा दरकार. Our appropriate seals for floor and ceiling. Then floor and ceiling रे कौन सी defect न थी वो. Dirty utility room, that should be presence in the facility. Then away from the caregivers passing center, essentially दूरे रहिबो. Wash basin with facility for cold and warm water रहिबो, liquid soap रहिबो. It can operate in negative pressure, and there will be pedal trash bin. So pedal operated trash bin should be there. Next. So prevent entry of microbes. Skin and cord care, that is very important. ଆମର particularly ବେଶୀ organism ପଶିଥାନ୍ତି ଯେତେବେଳେ ଆପଣ IV cannula ଦଉଛନ୍ତି. IV cannula ଯଦି properly seal ନ କରିବେ, ତାର care ନ ନେବେ, central line ଟା very important, and directly organism will enter into heart or larger vessel, and ଆପଣଙ୍କର ବହୁତ ହଉଛି ଆମର ventilator associated pneumonia and other things, ତାକୁ ବି prevent କରିବାକୁ ପଡିବ. Then ଯୋଉଠି ICU area ରେ, NICU area ରେ ଆଉ ନ୍ୟୁଟ୍ରିସନ ବଣ୍ଡଲ ଆପଣ ଯୋଉ ଫିଡିଂ କରୁଛନ୍ତି, ସେଥିରେ ବି ଆପଣଙ୍କର କେତେବେଳେ IV ଲାଇନ ଦିଆଯାଉଛି, ଇଣ୍ଟ୍ରାଭେନସ୍ ଫ୍ଲୁଇଡ ଦିଆଯାଉଛି, ଆପଣଙ୍କର କେତେବେଳେ ଦିଆଯାଉଛି ତାକୁ ଓରୋଗାଷ୍ଟ୍ରିକ୍ ଟ୍ୟୁବ୍ ଫିଡିଂ ଦିଆଯାଉଛି. ତେଣୁ ସେଥିରେ ସବୁ ପ୍ରିକସନ ନ ନେଲେ ଅର୍ଗାନିଜମ ବିଭିନ୍ନ ଏରିଆକୁ ବ୍ଲଡ କୁ ବା GI ଟ୍ରାକ୍ଟ କୁ ପଶିବାର ସମ୍ଭାବନା ରହୁଛି. ନେକ୍ସଟ. So this is the vernix that is protective during newborn when the baby is born. So try to remove whatever can be removed by the clothing, but don't rub it. The diaper you must apply properly, so that there is minimal soiling of the bed area, and all these things are given here. While preparing for IV line, you must take extra care. Do it very aseptically. First do hand washing, then take everything in a sterile tray, kidney tray. Then you wear gloves and do it with a minimum of invasive technique and putting it together. And after doing the procedure, you will have to hand rub and or hand wash so that you clean, your hands are clean for the next preparation. While giving IV, that is very important because when we are putting the Venflon, when Neocan, particularly Neocan has got the opening, you must open it carefully and give the injection. When there are double system, then you can use one for injection, one for the saline. And this is the bundle of prevention of this neonatal sepsis, where hand hygiene, maximum barrier precaution while inserting the line, and chlorhexidine skin care you will have to use for anti-sterilization of the skin around, and you must use this line maintenance by multimodal education and training program. Check entry site for inflammation and dedicated lumen and for TPN. You will have to prepare another line for TPN and daily review the line is necessary because these are the points of entry of organization. So the bundle is hand hygiene, VAP care bundle is hand hygiene, endotracheal tube care, then your head elevation 30 degree, higher lateral position, stress ulcer prophylaxis, then oxidation and oral hygiene, and daily assessment of readiness to win. So the whatever period is required, you put IV line, and whenever the patient can take orally, change over. Okay, next. So this is step 5, decrease susceptibility by preventing malnutrition and encourage express breast milk use, early breastfeeding, and kangaroo mother care, and involve mother in baby care activity as early as possible so that her confidence level becomes high and she is able to take care of the baby. And by the time we discharge from the hospital setup, she manages her baby in a better way. Next. So this is some of the areas shown how we can do. Then another area is our milk bank. As we promote breastfeeding and express breast milk, then we are producing milk banks and comprehensive lactation management units, and we are being promoted at several places. And at Sishu Bhavan also we are going to open a new one. At SCB there is also one unit, CLMC unit. So we will have to provide kangaroo mother care as close as possible. One baby, single baby, and here is twin baby. Twin baby being put in kangaroo mother care. So we'll have to send and record blood culture. We'll have to and we'll have to this written antibiotic policy. Strict use of that part is being dealt by the next speaker, Dr. T.V. Ramkumar. And we must restrict the use of reserve antibiotics. And we must have written infection control policies and hospital infection control committee and motivation by staff leadership for nurses and dealing with epidemic. So these things are to be done when there is many times very resistant drug resistant strains. There occurs epidemic in NICU or in a sensitive area. Then we will have to go for specific measures for fumigation or cleaning, extensive cleaning, and to control the infection. Before that, the infection control team committee should review it time to time, and they should take swab and do culture and designate which areas are affected, and so that preventive steps can be taken. So these are very important in saving life and preventing neonatal sepsis in newborn babies who are highly susceptible to infection. Next. So we have almost covered most of the aspects of neonatal sepsis. So in this connection, we'll have to remember that clean is very important. Dryness is also important because any water, any wet area is prone for infection. So another thing is that we must use disposables, that is single time use and throw, and properly we must dispose the used disposables, and we must have a bundle care for prevention of neonatal infection. So thank you very much. So we have covered the various aspects of newborn prevention of newborn sepsis. So with this, I thank again the organizers for giving me opportunity to speak on infection prevention. So I hand over the mic to organizers now.
Thank you, sir. Thank you very much for nice deliberation. Actually, एइथिरे जो कंपोनेंट्स गुडिक थिला केमिति माइक्रोब जर्नी करे को जगह बाहर एवं को जगह पहुंचे इन्फेक्शन हवा पूर्व जो पांचटी कथा सार सेशन नेले बहुत इंपोर्टेंट थिला हम पई एवं विशेष भाव में हमर एसएनसी और एमबीएससी रो स्टाफ मानक पई बहुत गुरुत्वपूर्ण थिला तेनो बहुत धन्यवाद सर को एवं मु आशा करिवि जदि क्वेश्चन किछ अछि लास्ट रे आंसर हमें खोजिबा सर जॉइन करिथिबे हम संगे जदि किसी पार्टिसिपेंट मानकर क्वेश्चन थिबा हम तार आंसर खोजिबा एवं वर्तमान मु रिक्वेस्ट करबी हमर डॉक्टर टीवी रामकुमार सर who is the associate professor in pediatrics now working at PRM Medical College Baripada Mayurbhanj sir को रिक्वेस्ट करबी सर नेक्स्ट सेशन रैशनल यूज ऑफ एंटीबायोटिक्स केमिति यूज करिवे केउ समय यूज करिवे केतेले न नेबे से विषय टिके आलोकपात करिवे over to Ramkumar sir. Ramkumar
Yes, sir. Thank you, sir. So, respected DFW sir, Prabhakar sir, BK Bhuiya sir, Aditya sir, Meena Som, and the fellow panelists. ଯେତିକି ଏଠି ଉପସ୍ଥିତ ଅଛନ୍ତି ସମସ୍ତଙ୍କୁ ଗୁଡ୍ ଆଫ୍ଟରନୁନ୍ ସେଠୁ ଯଦି ସ୍ଲାଇଡ୍ ଆରମ୍ଭ କଲେ ମୁଁ ଏଠୁ କଣ୍ଟିନ୍ୟୁ କରିବି
okay
हाँ so आमे इंट्रोडक्शन रे because what from where we have left आमे जदि सेटू देखिबा कि how can we prevent infection by सबटू most important होची early breastfeeding encourage breast milk and use of LMU facility जोटी हे परिबो सेटी आमे करिबा and सबटू important support the mother holistically and make her comfortable so that she can give the care restrict the IV fluids remove the IV line as early as possible in and institution of FPC and KMC. FPC and KMC is the best form of FPC. So that माने नॉट्स रो रेशियो टा हमरो सडनली जेति की तो अछि बहुत कम अछि सो बाय FPC and KMC हमें तांकर कामटा आउरी कम करि परिबा and very important we should give the positive feedback and encouraging the not personnel who are working already tired like nurses and staff सबु माने शॉर्ट रे अछंती तांकु हमें as far as possible positively हमें तांकु जति माने तांकु encourage करिबा जे positive काम करछन तांकु हमें टिके प्रशंसा करिबा so that will be the best spread to others and it will be the best motivation to them how entry color को as said hand wash hand rub cover गोटे मोबाइल ऊपर लगेबा and while you are using IV line की बाकी जिनस जो भी प्रोसीजर करछंती use of a small bedside हमरो जो bedside almirah जोटा थाए that is movable so usually हमें सेंतियारो easily मिल जिवो कि बट ट्रॉली मिल जिवो which can be used for keeping the sterile objects like IV line देलालको हमें जेमती से जोतरे पिला स्विच ग्रीन कलर ताकू जेति पर्यंत टच करिबा नाही okay so with this now I am going to the topic rational use of antibiotics in the newborn the first line is that ame rational use of antibiotics 90% talk devar achi ki probably antibiotics are not required so that is the most important message which from starting hobo so maximum time more jo message ta rahibo that not to use antibiotics and jodi bhi use karuchu we should follow a written policy next so antimicrobial भितरे हमरो antibiotic आसु antiviral आसु antifungal आसु so in these all kind there are many institutions where we have to also use the antifungals especially हमरो extremely low birth weight infants there are some selected situations where हमरो candid in urine आसिलाल को हमें जो antifungal institute करछो so these also so recognition is very important critical points but it is not that कि हमें prophylactically समस्त को कौन सी मेडिसिन दे दबाटा ठीक नहीं है so we have to recognize that antimicrobial resistance एपे ए वर्षर जो टॉपिक टा जो अछि they include the antibiotic antiviral antifungal next so we see why do we start actually antibiotics in SNCU or any place one we feel that the baby is sick okay and remember every sick baby or every sickness is not due to sepsis. That is the fundamental. Number two, baby both choto achi. So small or very small baby, extremely preterm, so they will be giving. Third, some say not a valuable baby, IVF baby. So the gynec obstetricians manankar pressure thibo ki this is a very valuable baby, sir. Valuable baby mane kon? See, this is a very, it is the worst term which is ever possible. For us, any baby who is getting admitted into SNCU is valuable. So every life is valuable. So these word valuable, we should totally discourage from them. Then the fourth one is the own relative or some known to patient. So the asijibo, then we say that ki are nijjara helalku are tike de deba kai ki risk naba. So in all the situations, everyone, many of us know the real cause is probably not sepsis, but we start antibiotics because there is a pressure or fear of losing the baby. This dar will cause us to make errors. So we should first able to control our that urgent fear of losing the baby, and we should start rationally. Next. So in this slide, now we will see some. Next. So you can see in this slide, now I can ask any of the nurses who are there, can tell in the you can just if possible, can you want to start antibiotic or not? Like if the baby has come not feeding well, so in all the baby, any baby not feeding well, will you start an antibiotic? So the answer should be no. It is multifactorial. Whether it is due to the sickness of the baby, some the gestation is not enough, so that is the reason, or the mothers there is a problem. So probably I know that everyone cannot unmute and speak, so that's why I cannot ask you. So I'm just discussing this, okay? But so definitely not feeding well is not sufficient to start an antibiotic. It is one of the symptom. Number two, birth asphyxia. Birth asphyxia, very serious baby. Baby may die, but baby does not require an antibiotic. Convulsion. In convulsion, there are so many causes of convulsion. Birth asphyxia leading to HI, hypocalcemia, hypoglycemia, then in all these things. Then there is a special in even to jaundice. Then bilirubin-induced neurological damage. Then a small part is played by the sepsis and the meningitis, jaundice, pathological jaundice. There are units where even every baby who is coming with jaundice also is started an antibiotic. So that is very dangerous. Okay, so I am talking about whenever I am discussing that, I am telling that these are been starting. So it does not mean that every unit is starting, but there are some small units which are there still in this state where they have the they are starting. So that is why I said this very low birth weight. So very low birth weight also, just the weight is not the criteria for starting the antibiotic. Even the baby can be extremely low birth weight also. 700, 800 grams. Baby does not require an antibiotic. Abdominal distension. Even just some lack of sometimes just some mild degree of feed intolerance, baby not pass through, that can be the reason for abdominal distension, may not be obvious sepsis. So no. Anomalies like tracheostomal fistula, cleft lip, cleft palate, any such anomalies which are there, they are also not the indication of antibiotic. Skin infection, like skin infection, definitely we will discuss regarding the skin infection and umbilical discharge separately. Then comes the MSL and MS. So remember, meconium in a newborn is sterile. So even if the baby is aspirating meconium, it does not warrant the use of antibiotics. Hypothermia and hyperthermia in itself can be a sign of sepsis, but environmental causes, but lack of keeping the baby in a proper atmosphere can lead to these conditions, and simple correction can avoid a lot of antibiotic misuse. Diarrhea in most of the cases in the newborn is because of transitional stools, and there are many places where either they are given maybe like Colicate drops, or sometimes they are given some probiotics, and even some places they will be given antibiotics also. And vomiting, diarrhea, these all are non-specific symptoms, and these all by in isolation do not correlate with sepsis. Next. So rational use means we should know what identify the risk factors for the possible sepsis, clinical features we should identify, then diagnosis of sepsis by screening, and then we have to confirm. Then finally comes this treatment, which is a small part. And next. So what are the risk factors for sepsis? We should know that there are two categories: superficial and that is superficial local infection, and the systemic infection. Systemic infection is called as sepsis. Next. For superficial omphalitis, redness or induration around the umbilicus or pus staining from it, that is regarded as a local infection. So just clean with antiseptics followed by application of mupirocin or half strength, 0.5% is full strength gentian valet 4 times daily. Okay, if there is severe, then redness is extending more than 1 centimeter of the surrounding tissue, we should think of sepsis. We can give antibiotics. I have written here precisely oral amoxicillin for 5 days because before 2022, the guideline of IMCI was to place this category in the possible serious bacterial infection, but now this has been moved into local bacterial infection. Next. Second is the conjunctivitis. There are different causes: chemical, chlamydia, gonorrhea, so it is technically rare. So most of the conjunctivitis which happen in the newborn is because of the amniotic fluid that enters and just irritates the eye. And by simple cleaning the eye from medial to lateral using separate cotton, sterile cotton, that is sufficient. Neonatal pustular melanosis, again the local application of mupirocin and the oral amoxicillin for 5 days. Next. Neonatal sepsis, generalized, okay, so it may be localized to lungs, meninges, bones or joints. So early onset sepsis by risk factors, because this will, if there are risk factors, then we can start the prophylactic and the antibiotics, and then if the sepsis screen comes negative, we can stop, so that there should be an option. So for early onset sepsis, that is less than 72 hours, the risk factors include the flora from the maternal genital tract and the delivery area. So risk factors are prolonged rupture of membrane more than 18 hours, foul smelling liquor, multiple PV examination or the more than 2, maternal fever, prolonged labor. So usually the baby presents with the pneumonia. Organisms in developing nations, both early onset and late onset, the organisms are same, which is the E. coli, Klebsiella, Staphylococcus aureus. In developed, there are variable. Okay. Yes. Next. In the late onset sepsis that occurs more than 72 hours, the risk factors include the external environment, if the baby is in the community, and if the baby is admitted in the hospital, that is the hospital environment. So here the poor hand hygiene, lack of breastfeeding, poor cord care, superficial infections, IV fluids, skin disruption, bottle feeding, aspiration of it. So these all will go and contribute. Clinical features will be sepsis, pneumonia, meningitis. Organisms, as previously mentioned, Klebsiella. In our context, most of the cases we get Klebsiella and Staph aureus, and the others are rare. Next. Clinical features of neonatal sepsis. They are definitely vague, ill-defined symptoms. High index of suspicion is required, and the characteristic, if any baby is well, we know if the baby is maintaining temperature, maintaining airway. Airway means the baby is having no sound or no noise, no secretion. So this is characteristic of good airway. Good breathing. So work of breathing is normal. Good circulation. So CFT is less than 3 seconds and the heart rate is less than 160. And baby is having C, means conscious and alert activity. Feeding is good and the baby is alert. Khatam. So this means the baby is good. Then the early signs are altered feeding behavior. A baby which was previously feeding well, poor feeding, refusal to suck, lethargy, unresponsiveness, poor cry, irritability, apneic spells, fast breathing, chest indrawing, grunting. In GI, like vomiting, abdominal distension, mucosal bleeding. Then in if it is severe NEC, kidney renal failure, congestive heart failure, scleroderma. So there is a lot of spectrum of things which are there, and in isolation, a single symptom by itself should not tell that the probability is sepsis. So we should combine the things. Next. As per the IMNCR, now you can see that 0 to 2 months, which is a part, obviously newborn are included in it. So any one of more of the following signs, like not able to feed at all or not feeding well, convulsion, fast within 60 breaths per minute, and especially important is that this is less than 7 days, only less than 7 days. Okay, if the same fast breathing, if it is above the 7 days, okay, then it might be considered as pneumonia. Here it is severe sepsis, severe chest indrawing, auxiliary temperature very low or very high, movement only when stimulated or no movement at all, then you should think that probably, next slide, the baby is suffering from possible serial bacterial infection, or it can be meningitis also. So if this baby is in the community, then give anticonvulsant, then first dose of IM MP Genta, then treat to prevent low blood sugar. So keep TABC along the way and refer urgently to the hospital. So the message here is that the diagnosis is called as possible serious bacterial infection or very severe disease. The name is PSBI or very severe disease. So in that level where they are sending, they have no capacity to differentiate various things. So for them, they are giving first dose of antibiotics. So if at all there is a treatable cause, that is treated. But once the baby reaches to the referred center, there the clinician has to use his clinical acumen and other tests to classify. The other one, which I said, is the fast breathing, 60 isolated fast breathing is regarded as pneumonia. So it is not a PSBI, it is pneumonia, in which you can just, if the baby is not having low weight for Hess or any severe classification, we can complete the oral amoxicillin for 7 days, and this oral amoxicillin includes the 30 mg per kg per day for 7 days. So in other cases, we are giving 25 mg per kg per dose BD for 5 days. Here you are giving 30 mg per kg per dose BD for 7 days. Next. So sepsis screen is very vital once the baby reaches. So more than 2 or more should be regarded as a positive screen, and most important is that negative predictive value of 2 screen 12 to 24 apart is very high. So positive se zyada, negative is more important. So TLC less than 5000, ANC less than 1800, IT ratio, CRP, micro SR, out of which again the IT ratio, micro SR are very difficult in many of the centers, not done. So but 3 TLC, ANC, CRP are done in almost all the centers where you are doing CPC and CRP. So kindly respect these 3 values and treat accordingly. Next. Approach to neonatal sepsis rate, very important is that once we are suspecting sepsis, you can start antibiotic if the screen is positive or if there are a lot of risk factors, but kindly send a blood culture in the periphery. In higher centers, we can send the bacter and the blood culture. Remember, in many of the centers, even our blood culture is being done because of Nidan scheme and other PP schemes. So kindly send some samples, because each hospital needs an antibiogram of its own. So that is very, very critical. So you can see even in very high NICUs where there are so sick babies, the organisms in itself like Acinetobacter, Pseudomonas, the incidence is very high. So their first choice of antibiotic is different from what we use. Okay, so kindly and remember, whatever preventive measures you can do, whatever treatment measures you can do, these all are very, very nicely can be done in the lower level rather than the medical college, in the centers where are so much overcrowding. In these places it will be much difficult, but in a place where there will be one baby in a bed and you are having more freedom to do such things, and kindly send blood cultures and build your antibiogram. That is vital. Next. So now the treatment of any baby, coming to the supportive care, and then a small part always by the antibiotics. And always remember, antibiotics are the supportive care always ensures the TABC and the glucose, ensuring optimal nutrition. So as I said, start enteral feeding. Do not try to keep the baby NPO, and please, if the gut is well, even a child with pneumonia or some sepsis can also receive the nicely the feeds through orogastric tube. So at least don't deprive the child of the nutrition, and as early as possible try to increase the quota of feeds. Any baby who is above 1.2 to 1.3 kg, straight away give full feeding. Please do the abdominal girth, and that's enough. The incidence of necrotizing enterocolitis or feed intolerance between the groups which have started full feeds, matlab more than 1.2 kg, and those who are giving slowly, the incidence is almost same. So we need to fear less, and we need to start enteral feed, because this is the way by which we will not put lines. Okay, so we will be very happy with that, and please encourage the mother, support her to bring milk. Antibiotics always the choice, as in our center when we did our most of the organisms, even like Klebsiella and the Staph aureus, which is growing in which has grown in our place, is universally almost sensitive to amikacin. So there it was registered. So some were resistant to cefotaxime, some were not. But amikacin, 90% se zyada amikacin was sensitive. Even the so we will prefer to use the amikacin. There are centers in which netilmycin is sensitive. So some people in some centers have even started netilmycin as a solo antibiotic as the choice to start with. Okay, and as per the culture report they will change. But for our guideline, we will prefer to start with in any neonatal sepsis ampicillin and gentamicin. So this is very very vital, and respect. And you see that the most of the medications which are given like this, they are working very very nicely. 50 mg per kg per dose of ampicillin 12 hourly to previous slide. Yes, so that one, and gentamicin also 2.5 mg per kg per dose BD or 5 mg per kg per dose OD can be given. And if the suspicion of meningitis is there, so instead of ampicillin, cefotaxime can be added, and in place of genta you can give amikacin. So if we in our place, if we are suspecting meningitis, we start with cefotaxime or amikacin, and if we are not suspecting meningitis, we are doing cefotaxime and gentamicin. And once we see that within 40 to 70 hours there is worsening of symptoms, or there is some other, then we go for the second line, which is adding piperacillin tazobactam while omitting cefotaxime, and continuing amikacin. And if you are suspecting the condition as meningitis, then we will use meropenem. Again, there is a point which I would like to make, is that many places where there is some abdominal distension, they straight away would like to include the metronidazole. Okay, metronidazole they like to give. Okay, if the choice of antibiotic of adding metronidazole is good, if the baby is receiving ampicenta or cefotaxime amikacin, but if you are giving pipjo or piperacillin tazobactam or meropenem, so there is no necessity of adding metronidazole, because both piperacillin tazobactam and the meropenem have got good anaerobic coverage. So adding metronidazole to this combination will not provide further help. So always we need to look at the these conditions, and especially as per the gestation of the baby and the number of days, that is less than 7 days, more than 7 days. If fairly nice guidelines have been given to the in the FBNC book and also in the NBSU book, so that can be very easily followed. Okay, and those who are working in medical colleges and higher centers, they follow the neofax guidelines, where they are given in much more detail. The duration of the antibiotics is around 10 to 14 days. If there is a pneumonia, UTI without sepsis, the guidelines says you give for 7 to 10 days. Also in culture positive proven sepsis, you can give around like 10 to 14 days. And if there is meningitis or there is like septic arthritis, in such cases, we can prolong the antibiotics to 3 weeks. Sometimes where there is a severe gram-negative hospital-acquired infection, so we need to demonstrate that the culture has become negative in some cases. But otherwise, these are the fair guidance. So whatever it may be, in most of the cases where we are starting the antibiotics for our safe good feeling, maybe we presume that because we have not taken good care in the asepsis, so probably antibiotic is like the shield for that, covering those defects. Never, never and never. So this is what antibiotics cannot cover the defects what we leave in the hand hygiene care. So we need to again stick to the basics: hand hygiene, hand wash, good early enteral nutrition, involvement of the mother and other caregiver in the care, that is the family participation care, so that and you can form the the doctors and nurses can work together, that they can in where the antibiotic use is very high, they can start looking that okay, from 1.5 kg onwards or 1.2 to 1.5, I will not give antibiotic. Okay, you can start doing that. You start doing that exercise for some babies, and you see that the rate of the worsening or the death will be no different. So in this way, you yourself can prove. So this is what is called as like a POCI model, or a point of care quality improvement. You can improve yourself, and whenever there is incidence of such sepsis and other things, do not try to pinpoint each other and don't try to disgrace the staff and yourself or the sweepers, because they're already working and tirelessly. So we need something to improve ourselves holistically, and we can do some minor changes in our mindset and our work, and we can give some positive feedback in which they can take it easily without criticism. Then probably the change which will come might be slow, but it will last much longer. Next. So as I said, because it is all the fear which is there, not so डर. So डर से मत डरो, क्योंकि डर के आगे जीत है. And definitely we can, that jeet is that we can preserve the antibiotics for our future generation, so that they will be preserved. But if we go on using the antibiotics, probably we might harm this baby due to the side effects of the drug, and in future development of resistant organisms, and in future the antimicrobial will be historical. So we need to then will be nowhere. Thank you.
Thank you very much, Dr. Ramkumar. Really, your speech was very excellent. I think that will give learning points for all the service providers in SNSU. Now, next speaker is our Vijay Kumar Bhaiya sir, President IAP. He has got very nice presentation on rational use of prescription, how to prescribe medicines, because ଏବେ ଯେମିତି ଆମେ rational use of antibiotics କଥା ହଉଛେ, ସେମିତି prescription ରେ ମଧ୍ୟ ଆମର ବହୁତ ଗ୍ୟାପ୍ ରହୁଛି. ପ୍ରେସକ୍ରିପସନ ରେ ଗ୍ୟାପ୍ ରହିଲେ ବହୁତ ଯାହା ତ ପେସେଣ୍ଟ ସଫର କରିବେ ବା ମେଡିସିନ ଦୋକାନୀ ସଫର କରିବେ ଏସବୁ ହବ, କିନ୍ତୁ ତା ସହିତ ମେଡିକାଲ ଲିଗାଲି ମଧ୍ୟ we are responsible as a doctor. So ସେଥିପାଇଁ ସାର୍ ଙ୍କୁ ମୁଁ ରିକ୍ୱେଷ୍ଟ କରିବି, ସାର୍ ତା ଉପରେ ଟିକେ ଆଲୋକପାତ କରିବେ ଯେ how to write proper prescription. Sir, over to you, sir. ମୁଁ screen share କରିଦଉଛି ଆପଣ.
Share my slides.
Yes, sir.
Good afternoon, everybody. Director Family Welfare, Dr. Sanjukta Sahu. Dr. Aditya Mahapatra, Additional Director. Am I audible? Am I audible?
Yes, sir.
Yes, sir.
Then the other faculties, Dr. Prabhakar Mishra, Dr. Minash Om, Dr. T.V. Ramkumar, all the participants, which includes also probably many health administrators. I'm thankful to the Director Family Welfare for giving this opportunity to me to talk today.
Is it visible?
Yeah. Thank you.
Sure.
See, my topic today is legible and rational prescription, a comprehensive approach for optimal patient care. As you will be seeing, this topic is out of sync so far as today is concerned, because we are observing the newborn week and we are discussing about the newborn. But the rational antibiotic therapy is only a part of a rational prescription. So it has got some relevance. I gave this talk in the recently concluded Odisha State Pediatric Conference. And the additional director, who happens to be a pediatrician, also heard this talk, and he wanted me to give this talk today because it has got a lot of relevance so far as today's situation is concerned. Many of you might have heard this topic in the conference, so I request to those who have heard already to bear with me. This not only concerns pediatrics, this today's talk not only concerns about the pediatricians, neonatologists, but also concerns all branches of medicine. Please hold on to that topic, initial. It concerns all branches of medicine, whether you are a medicine, surgery, gynecologists, dermatology, or any branch of medicines. It concerns all doctors and all health administrators. As you know, legible and rational prescription is nowadays, you might have seen many prescriptions are legible and irrational. This is really a matter of concern. And the purpose of my presentation is to give you a food for thought, actually, what we can do to improve on this. As you know, this prescription has got two components, legible and rational prescription. Either if your prescription is not legible, there's no meaning if you give a rational prescription because nobody can read it. Even if your prescription is legible and prescription is irrational, also it carries no meaning because patient is not going to benefit. But your prescription has to be legible and rational. That is good for everybody. It is good for the patient. But if it is illegible and irrational, that is the worst thing that can happen to the patient and to the society. So, with these few words, I am going to present my talk, and I hope it will have a lot of food for thought for all of you. Next. Next, please. What is a legible prescription? Legible prescription means a prescription or medication order issued by a practitioner, licensed by law, is capable of being read and understood by the pharmacist, nurses, and other practitioners, in addition to the patients or relatives. Next. What is the law pertaining to legible prescription? Clause 1.5 of IMC, Professional Conduct, Etiquette and Ethics Regulation 2002 prescribes that every physician should prescribe drugs with generic names legibly and preferably in capital letters, and he or she shall ensure that there is a rational prescription and use of drugs. Not only there is an IMC provision for this, I think already there is a guideline from the government as well as from the court also regarding legibility of prescription. Next. These are some of the examples I have collected. This. How can the prescription be illegible? See, on the left side, you can possibly say something written in English. But on the right side, you do not know whether it is English, whether it is Greek or Latin. So this is the legibility of this prescription. Next. These are few examples I will show you next. This is again some prescriptions where, no, please, previous one. Here on the left side, possibly you cannot read anything. On the right side, you can possibly read 50% of the prescription. Next. This is a discharge card of a pediatric hospital where the discharge card, this is illegible. Once it is illegible, you do not know whether it is rational or it is irrational. Next. So what is a rational prescription? by definition, rational prescribing describes a logical approach that includes making a diagnosis based on history and physical examination, if necessary with investigations. You can make a differential diagnosis if obvious the diagnosis is not there, establish the goal of therapy, select most appropriate treatment, and monitor the effects of treatment. Next. In a recent ICMR study of 2019 to 2020, which has been published in Indian Journal of Medical Research, which includes all hospitals all over India, including tertiary care hospitals of India. 45% of the prescriptions, that means out of 4,838 prescriptions that were audited, 2,171 were incomplete prescriptions. 10% of them in tertiary care hospital, like Sabdarjung and All India Institute of Medical Science, had unacceptable deviation, which means there is inappropriate prescription of medicines and more than one diagnosis. Next. What are the components of rational prescriptions? Which includes prescribed substance name, qualification, registration number, and contact information, date of prescription, patient's name, registration number, age, sex, weight, and height. History and physical examination, diagnosis and differential diagnosis, medication, follow-up, signature. See, out of these, if you see first three up to patient's name, nowadays I find the reception already gives a computerized description to you where everything is written. The doctor is to start writing from history and physical examination. Next. History taking is very, very vital. What is the chief complaint? History of present illness, past medical history, family history, immunization history. For a pediatrician, it is very, very important to take the family history and immunization history. Next. Physical examination includes a thorough physical examination, including general physical examination, systemic examination, and identifying physical signs related to the chief complaint. Next. Diagnosis is mainly based on history and physical examination. In fact, if you take a thorough history and do a good physical examination, more than 80% of the cases can be diagnosed without any further investigations. But if you still cannot diagnose, then you can go for investigation to make a complete diagnosis. Next. So there are 5 R or rights of medications. Right patient, identify the patient's need for medicine. That's the right drugs, choosing the most appropriate medicine, right dose, right route of administration, and the right time of administration, determining the appropriate timing, frequency, duration, and medication. And the 6th right I can include is the right to refuse. Next. Why it is important in pediatric practice? Because pediatric has got a unique considerations, difference in pharmacokinetics and pharmacodynamics, age and weight specific dose calculation, age specific adverse effects. Next. Challenges in pediatric prescribing. These are limited clinical trials, in some cases leading to off-label use, complex dose calculations based on weight and age, difficulty in medicine administration. Next. Pharmacokinetics in children vary. Absorption varies with age, gut motility, and gastric pH. Distribution influenced by body water and fat composition. Metabolism, immature liver enzyme in infants, which hampers metabolism of the drug. And excretion of the drug in the kidney also because of the immaturity of the kidney in small infants. Next. What is the importance of follow-up advice? Monitoring treatment efficacy and side effects, ensuring patient adherence, warning signs to watch for, and schedule for follow-up visits. Next. These are some of the examples of irrational prescriptions. If you see the prescription on the left side, which has got the name, age, 6 months, and male, you do not have a weight mentioned, no diagnosis mentioned, fever cough for 3 days, no diagnosis, no physical examination. And the antibiotic, first is the antibiotic, Teximo, which is a cefixime. From the history, as you know, there is a fever, cough, and cold. That means the possibility of viral fever where the antibiotic is not warranted. Even if antibiotic is warranted, this is not the proper antibiotic because this is cefixime, which is not indicated in upper respiratory infections. Syrup PCM 1 TSF SOS. 1 TSF means what? The concentration of the drug is not mentioned, whether it is 100 milligram or 250 milligram. 1 TSF is how much? Then syrup something half TSF TDS as half TSF. BD. Actually, prescription should not be written in this way. The strength of the drug and how many times to be taken, when to be taken, those should be proper. And see, this prescription is absolutely irrational. Next. This is another prescription you see. There is no complaint not written, examination finding not written, diagnosis not written. Straight the doctor goes for advice. What is the advice? PCM BD. What does it mean? What PCM? What is the strength? And when to take BD. See, normally fever comes very frequently, every 4 to 6 hours, you have the doctor write BD. Actually, BD, TDS, QID should be avoided in a prescription. The patients do not follow this. Next is syrup azithromycin. Again, strength is not mentioned, whether it is 100 milligram, 200 milligram, and BD doses. Salbutamol. Again, the strength not written, it is BD. So this sort of prescription causes more harm to the patient than doing any good. This doesn't contain the diagnosis, medicine strength not mentioned, dose duration missing. And this is not a single prescription. You find many of these prescriptions like this. Next. So this is a prescription where I couldn't actually read actually what is this something written. What I could know from the CT scan report is patient had a fall actually. This is a child who is 8 kg, patient had a fall, has been advised for CT scan. CT scan report is normal. I think the patient, any patient comes with a fall, a thorough clinical exam is necessary with history and physical examination. In most of the cases, actually not require a CT scan. If you do a thorough and physical examination, with an advice to the patient, if this happens in next 48 hours, please come back. Because advising a CT scan not only involves money, but also involves radiation. So not that any patient comes to you with fall, you advise a CT scan. This is not done actually, not very rational. This is a grossly irrational way of treatment. Next. Again, a series of prescriptions which are absolutely irrational. Patients comes in the morning with gastroenteritis, you give some medicine. Then after a few hours, you admit this patient. Then you start giving fluid, give amikacin and captive action. And in the evening, the patient is discharged on request. Next. Next. No, previous prescription, can I have it? The previous one? Yeah. This on the left side, you see diagnosis written as APD, acid peptic disease, which normally you do not find in a child. Pantoprazole and something else written. On the right side, diagnosis is URI, but the patient is written Defi lotion, Defi soap, and Defi and everything except the prescription of URI. Next. This is again another prescription of irrational prescription. Okay, next. Proper documentation and communication is important. Accurate documentation regarding history, examination findings, diagnosis, and prescription detail is mandatory, which is missing as I showed you in all of the prescriptions. There is an importance also of informed consent. Next. Adverse drug reaction is very, very important. Type of adverse drug reaction the patient has, monitor and report. Minimize the risk by explaining the patient regarding the adverse drug reaction of the drug that you have prescribed. Next. Role of healthcare providers. The need for interdisciplinary approach if you are unable to diagnose a case properly. Collaboration among doctors, nurses, and pharmacists for proper implementation of the order. Continuing education is very, very important because so that your knowledge gets updated. Keeping up to date with latest guidelines and research. That only lead on to a proper and rational prescriptions. Next. Parental involvement in pediatric practice is very, very important. Educating parents regarding the disease, proper administration of medicines, and abuse of antibiotics. See, most of the time the child refuses to take medicine, how to give medicine, what to do, all these things to be explained. Recognizing the side effects. Patients have to warn that these might be the side effects. Please report if you get the side effects. Involving in the treatment for adherence of treatment and follow-up of treatment. So parental participation in pediatric practice is very, very important. Unless you explain to the patient that it's no meaning in just giving a prescription and tell the patient to go away. Next. So summary and take-home points, importance of legible and rational prescriptions. As I have shown you, there is a definite need for a legible and rational prescriptions. And there is a food for thought for everybody, in fact. If our prescription is not legible and rational, then that the patients and the society suffers. So how this can be done? There is a need for sensitization to the doctors. If the sensitization fails, then what? Then there may be some accountability. There may be some law. Many times we have got laws which are not implemented. But this is a very, very serious issue that health administrations and all the doctors should take into account. Prescription audit. One should actually self-audit the prescription. Once you write the prescription, you yourself ask, is my prescription legible? Then ask if my prescription is rational, whether what I have written is correct. If you ask these two questions to yourself, then possibly in the next patient, you will give a better prescriptions. If you fail to do this, then the reverse way is, nowadays the patients have become very, very, aware of their rights and responsibilities. Many of them are also become Google doctors. So time will come, the patient will ask you, doctor, your prescription is not legible. Please give me a good prescription. Or he might ask you, if you are giving an antibiotic in a case of cough and cold, he might ask you, doctor, do I really need an antibiotic? So to save your face, you can say, yes, you need an antibiotic. But for the next person, you will definitely think that, yes, I should not use an antibiotic for a mere cough and cold. So these are some of the things that actually starts me, and I want to put this in your mind so that one should think about this, what can be done. Because these sort of things are not a very sort of occasional occurrence. Majority of the cases this happens. Prescriptions are not only illegible, but also highly irrational. So comprehensive approach, including history, physical examination, diagnosis, medication, and follow-up is very important. Ongoing need for vigilance and education. Next. So see the prescriptions, our prescription involves only the capsules and medicines, or the doctor is busy writing medicines. Thank you very much. With this, I stop my deliberation. Thank you again for giving me this opportunity.
Thank you very much for your nice deliberation. Actually, बहुत भलो थिला आपनकर rational prescription केमते हम लिखिबा mainly हमर youngster मन पई. Next move within 10 to 15 minutes विशेष भाव रे मु कहबी prescription audit विषय रे केना this is a program again in the quality improvement program हम जो quality cell कहउचे कायकल्प मुस्कान लक्ष्य ये सब रे prescription audit is also a part of this program. So हमको से विषय रे जानिया दरकार विशेष भाव रे हमर administrator माने manager माने ए सब जिंस जानिया दरकार so that हमें properly करि परिबा जे prescription audit मध्ये time to time करि परिबा. So मु से विषय के कहबी केना this is a program हमको जानियो गुडियो आगु मध्ये आपण prescription audit करिवे केतरा जगह रे recently न तो 2 वर्ष भीतर मु जानिबारे हमरो मानसी पंडा मैडम जेतळे एचओडी कम्युनिटी मेडिसिन थिले बलांगीर रे से प्रेस्क्रिप्शन ऑडिट ऑन डायरिया करथिले नुआपड़ा बलांगीर जिल्ला रे दैट वाज हाईली एप्रिशिएटेड बाय मिशन डायरेक्टर सेथि पे हमकु मध्ये निज निज इंस्टीट्यूशन रो प्रेस्क्रिप्शन ऑडिट करियो पड़िबो टू मेक इट लेजिबल सेथि पे आपण मानकु जानिबा दरकार जे व्हाट इज प्रेस्क्रिप्शन ऑडिट एवं से प्रेस्क्रिप्शन ऑडिट संपर्क रे हमें जानिबा एबटु काम आरंभ करिबा ताहले वर्ष 2 वर्ष भीतर मध्ये हमें प्रेस्क्रिप्शन को करेक्टली हम जगह दे परबा माने ठीक रे प्रेस्क्रिप्शन लिखबा पे बाध्य होबा हमर सर्विस प्रोवाइडर माने सो सेथि पे हमें जानिबा जे व्हाट इज प्रेस्क्रिप्शन ऑडिट एवं ऑडिट माने हम समस्त जानछे कि जे सिस्टमैटिक रिव्यू analysis and any service is delivered and evaluation in terms of quality within given resources आम पाखरे जहा रिसोर्स अछि सेवा को नेगिरी आमे ओटे रिव्यू करूचे एवं प्रेस्क्रिप्शन टा ठीक भाव लेखा होछि कि नै से विषय जानिया पे एटा ऑडिट कहंती प्रेस्क्रिप्शन ऑडिट सो एथिरे मेनली ये पार्ट ऑफ होलिस्टिक क्लिनिकल ऑडिट जहा में आमे जो मुस्कान प्रोग्राम आपण माने समस्त प्राय जानिथिबे सेथिरे आमे ए ऑडिट गोटे पार्ट रखिचे एवं सेथिरे जेतेबेले आमे जदि ऑडिट करा जाउछि रेगुलरली ताल मध्ये यू विल गेट सम मार्क so this is a process that the improvement of the patient care and outcome through a systematic review and care against explicit criteria so सेथि पे आमे प्रेस्क्रिप्शन ऑडिट को एबे बेसी ध्यान दोजे एवं प्रेस्क्रिप्शन ऑडिट करिया पे आरंभ करछे किंतु हम प्रेस्क्रिप्शन ऑडिट को हम धारा रे पकेबा तेनो ऑब्जेक्टिव ऑफ कंडक्टिंग प्रेस्क्रिप्शन ऑडिट हला आमे मेनली सार एबे ऑलरेडी देखै सारलेनी तेनो मोर इजी प्रेस्क्रिप्शन विषय कहया पई आमे प्रेस्क्रिप्शन रो डिटेक्शन करबा जे कोन एरर अछि इट इज नॉट फॉर पोलिसिंग बा आमे एमती पुलिस न जे चोर धरिया पई बट इट इज पॉलिसिंग माने आमे ताको रिफाइन करबा एवं बेटर कर परबा आउटकम बेटर हे परबो प्रेस्क्रिप्शन ठीक भाव लेखा जाय परबो तो सेथि पई एटा करा जाउची एवं बहुत जगह रे एबे भी आमे देखि छु बळे बळे जेतेबेले आमे जाऊ एसएनसी विजिट रे एवं एसएनसी रे लेखा जाइथियो डायग्नोसिस थियो बाथासिक्सिया एवं लेखा दियो एम्पिसिलिन एंटासिस प्रिस्क्राइब कराय दियो टिकेट रे सो इन व्हिच वे इट इज ऑथेंटिक मु बुझी पारे नि बा एथिकल केमिति आमे हेले सेति में हमकु आपन को के मना करना एंटीबायोटिक लेखिया पई किंतु यू गिव सफिशिएंट रीजन काहे के एंटीबायोटिक रे लेखिले तो सेति में हमकु इरेशनल यूजेस ऑफ एंटीबायोटिक सिरप इंजेक्शन यारो एको अवॉइड करबा पई यूजुअली हमें ए प्रेस्क्रिप्शन ऑडिट करबा पई जाउचे एवं नॉलेज मध्य बढ़िबो धीरे धीरे ग्रेजुअली हमरो सर्विस प्रोवाइडर मेनली डॉक्टर मानकर नॉलेज बढ़िबो ओपीडी रे आईपीडी रे जो प्रेस्क्राइब करछोंदी सेटा को केमदी ऑथेंटिक एथिकली प्रेस्क्राइब करबे एवं माने आमे अन्य मानक द्वारा जेमदी क्रिटिसिज्म रो फेस न करबा then this is the opportunity for improvement of our prescription and good practices को मध्य हमें एमती एग्जांपल देई देखै परबा जे this is a good prescription see how it is rationally prescribed एटा मध्य गुड प्रैक्टिसेस भीतर आसी परबो नेक्स्ट प्री रिक्विजिट्स ऑफ प्रेस्क्रिप्शन ऑडिट रे हमर कोन रहिबो मेनली बहुत जगह अपन माने देखियो हॉस्पिटल मैनेजर माने हमर कोया जाय थाय तांको अपन प्रेस्क्रिप्शन ऑडिट करिवे गोटे क्राइटेरिया रखिवे का कल्प पई बा लक्ष्य पई मुस्कान पई से माने जहा पाती करि दियंती किंतु एमिति अपन मान को करियो पड़ो गोटे स्टैंडर्डाइज प्रेस्क्रिप्शन फॉर्मेट रे करियो पड़ो एसेंशियल मेडिकल लिस्ट अवेलेबल होतबा दरकार सेठी बा हमर जो ईडीएल जोकरा हम कहू जे that should be available and all the service providers should be aware about this different level जो माने काम करूचंदी से माने जानि थिबा दरकार जे कोन कोन ड्रग अवेलेबल अछि मोस्टली मु भाउ जे आम स्टेट रे एटा स्ट्रीमलाइन हे जायछि सब पब्लिक हेल्थ फैसिलिटी रे जानि छन समस्त जे आमे को ड्रग आमे प्रिस्क्राइब करबा देन स्टैंडर्ड ट्रीटमेंट गाइडलाइन शुड बी अवेलेबल फॉर ऑल द सर्विस प्रोवाइडर्स एवं एटा मध्ये हमर गवर्नमेंट ऑफ इंडिया रो गाइडलाइन सब जाय जे हम जेंति नियोनाटल पय हम एपीएनसी गाइडलाइन फॉलो करछे चाइल्ड पय एफएमसी गाइडलाइन फॉलो करछे देन एनसीडी रो गाइडलाइन अछि स्वतंत्र भाव रे हाइपरटेंशन और डायबिटीज रे केमते आपण मैनेज करबे कोन कोन ड्रग फर्स्ट लाइन कोन सेकंड लाइन ये सब गुडी को अवेलेबल होता दरकार ताकर नॉलेज रहिता दरकार बिफोर गोइंग फॉर प्रेस्क्रिप्शन ऑडिट so expected outcome कोन ना improving prescription quality at public health facilities mostly हमरो CHC SDH DHH रे जते प्रेस्क्राइब करूचे हमें से हेल्थ फैसिलिटी रो प्रेस्क्रिप्शन टारे क्वालिटी इंप्रूव करबो रैशनल यूज ऑफ ड्रग्स हमें देखिबा गोटे गोटे प्रेस्क्रिप्शन रे 10 टा ड्रग 5 टा ड्रग लिखा जाइदिबो तो एक्चुअली सब ड्रग दरकार कि नाही एटा मध्ये हमें जानिथि दरकार then automatically that will reduce the cost of the treatment by reducing the unnecessary prescription एवं जेनेरिक मेडिसिन को हमको लिखिबा पे हमको कहा जाउची we have to write the generic medicine name in the prescription एई प्रेस्क्रिप्शन ऑडिट को माने फेस करिवे बा काहर प्रेस्क्रिप्शन को ऑडिट करा जाय परिबो से माने हेले एई हॉस्पिटल ले काम करथिबा हमरो डॉक्टर माने जो माने कि डिस्ट्रिक्ट हॉस्पिटल एसडीएच सीएचसी पीएच रे काम करचंदी एलोपैथिक डॉक्टर माने एमानकर प्रेस्क्रिप्शन ऑडिट करा जाय पारे केतेबेले भी कोनोसी मेडिकल कॉलेज मध्ये एटाको टेक अप कर जाय पारे जे आमे एई जिल्लार प्रेस्क्रिप्शन ऑडिट करिया पई चाहूछु एवं एथिकल कमिटी रो क्लियरेंस करे दे आर एलिजिबल फॉर प्रेस्क्रिप्शन ऑडिट एवं वर्तमान हमर प्रेस्क्रिप्शन गुडी को सब रहुची फार्मासिस्ट मान पाखरे होते स्कैन कॉपी एवं से स्कैन कॉपी रु से माने रैंडमली सिलेक्ट कर परिबे एवं सेटा को आपण प्रेस्क्रिप्शन ऑडिट कर परिबे एवं निज हॉस्पिटल ले मध्य हमर एडमिनिस्ट्रेटर माने एई प्रेस्क्रिप्शन ऑडिट को प्राधान्य दे परिबे एवं कर परिबे एंड आ गोटे जिंस होची आमे मेनली आमे एटा मेडिकल लीगल केस को इंक्लूड करू ना एथरे जो प्रेस्क्रिप्शन होची सेडा एथरे आसुनी सो तो these are all components तेनु हमको मेडिकल ऑडिट बा मेडिकल प्रेस्क्रिप्शन ऑडिट हमो डीएमओ होतु बा सुपरिटेंडेंट होतु सेथिरो से माने मध्य कर परिबे नेक्स्ट मेथोडोलॉजी विषय टी खाली म कहि दोची मेथोडोलॉजी रे आमे कोन मिसेस बार म कहली इट इज नॉट फॉल्ट फाइंडिंग इट इज फैक्ट फाइंडिंग कोन प्रकृत रे करबा कथा एवं कोन होची इट इज नॉट पोलिसिंग वी आर डूइंग पॉलिसिंग ऑफ द प्रेस्क्रिप्शन एंड इट इज एन इंटरनल मेकानिज्म फॉर क्वालिटी इंप्रूवमेंट पांच जन डाक्टर जदी सीएचसी रे अछंती से मानक भीतर प्रेस्क्रिप्शन ऑडिट करे आमे गोटे मीटिंग करिकरी सेठी मध्ये आमे डिस्कस कर परबा एवं फर्दर आमे एडवाइस दे परबा जे हाउ टू इंप्रूव आवर प्रेस्क्रिप्शन प्रोसेस एवं दिस इज द विशियस साइकिल जो थरे कि आमे फ्लो चार्ट हिसाब रे आमे केमती ए साइक्लिकल प्रोसेस को कंप्लीट करबा प्रॉब्लम जानिले तापरे क्राइटेरिया एग्रीड हबो मीटिंग रे एवं तापरे ऑडिट डाटा कलेक्शन हबो एनालिसिस हबो एवं तापरे मेक नेसेसरी चेंजेस एवं सेही मेथोडोलॉजी विषय रे मुके एठी कहबा पई चाहू सो दिस इज ऑफ कोर्स सेम एल्गोरिथम जो थरे कि आमे प्रेस्क्रिप्शन ऑडिट करिया पई जाउछे एठी गोटे जिंस होची आमे जति कि आम इंस्टीट्यूशन रो प्रेस्क्रिप्शन बाहरुची तार गोटे सैंपल साइज हमु नबागु पड़िबो एवं सैंपल साइज रो फॉर्मेट मध्ये मु देखै देबी केते ओपीडी पेशेंट आसुले आपण केते सैंपल लेबे तार डाटा कलेक्शन रो फॉर्मेट रे डाटा कलेक्ट करिवे देन एनालिसिस करिवे डाटा देन को कंपोनेंट रे लो स्कोरिंग अछि जेटा देखिबे तापरे इंप्रूवमेंट पे प्लान करिवे नेक्स्ट दिस इज फास्ट आपण माने ऑडिट कमिटी करिवे गोटे हॉस्पिटल रे जदी आपण प्रेस्क्रिप्शन ऑडिट करिया पे जाउचंदी ताले सेठी मेडिसिन एंड थेराप्यूटिक कमिटी नारे गोटे कमिटी करिवे एवं सेतिरे मेनली को माने रहिबे सजेस्टेड मेंबर्स हेले हॉस्पिटल इंचार्ज जदी डीएचएस बा एसटीएच कहउचंदी हॉस्पिटल इंचार्ज बा सीएमओ देन हॉस्पिटल एडमिनिस्ट्रेटर जदी अछंदी से रहिबे वन क्लिनिशियन फ्रॉम ईच डिपार्टमेंट इंचार्ज नर्सिंग ऑफिसर एंड चीफ फार्मासिस्ट तो ए माने होचंदी मेंबर इन द ऑडिट कमिटी सेमान को लेके आपण गोटे कमिटी करिवे नेक्स्ट फॉर्मुलेट करिवा परे देन जदी आपण सीएचसी रे करिवे चाहजंदी ताले मेडिकल ऑफिसर फार्मासिस्ट एवं गोटे जणे सीनियर नर्स मध्ये आपण नेगिरी ए ऑडिट कमिटी कर परिवे specific details like antibiotics prescribed medicines prescribed as a standard treatment guideline can be audited through the peer review by another medical officer माने जनकर प्रेस्क्रिप्शन आ जन मध्ये रिव्यू कर परिवे एवं तांकु सेठी सजेशन दे परिवे so scan copy of minimum 30 prescription can be sent to district quality assurance unit for review जहा को आपण कले तादरु 30 टा मध्ये आपण डिस्ट्रिक्ट को पठे परिवे indicator to check the completeness of the prescription patient details name age sex address ये सब जिंस रहिबो chief complaint diagnosis medicine information non pharmacological treatment description then signature अछि ना नै सेटा देखिबे एवं तार परसेंटेज केमति बाहर करिवे सेटा को हमें देखिबा परसेंटेज ऑफ प्रेस्क्रिप्शन विथ लेजिबल हैंडराइटिंग prescription where medicines prescribed in standard treatment guideline as per standard treatment guideline then allergy mention है ना नहीं prescription with a brief history अछि ना नहीं provisional or final diagnosis then salient features of clinical examinations are recorded and prescription where scheduled dose and drugs are written तो तापरे को केतेटा परसेंटेज ऑफ प्रेस्क्रिप्शन रे विटामिन टॉनिक एंजाइम लिखा है सेटा को मधो एनालिसिस हमें करबे सो स्टेप 2 रे कैलकुलेट सैंपल साइज केने हमें सैंपल साइज जो जानिबा हमहु इजी हे जे परबो ये सब होला फार्मूला किंतु मु आपन को पूरा डायरेक्ट सैंपल साइज रे हिसाब देखे दोची नेक्स्ट स्लाइड रे दिस इज सैंपल साइज माने करो गोटे ओपीडी रे अटेंडेंस होची 10 टी ताले सेठी 9 टी सैंपल को नबाक पड़िबो 9 टी प्रेस्क्रिप्शन नबाक पड़िबो सेमिति जदी 500 होची गोटे जगह रे ताले 81 टा सैंपल लेले प्रेस्क्रिप्शन लेले ताको आपन गोटे माने एडिक्वेट सैंपल साइज हैला बोली जणा पड़िबो 300 रे 73 200 रे 66 प्रेस्क्रिप्शन एमती करिकरी आमे सैंपल साइज कैलकुलेट कर परिबा एवं सेतिकी सैंपल प्रेस्क्रिप्शन देई कि आमे ऑडिट कर परिबा तापरे आसला डाटा कलेक्शन एवं डाटा कलेक्शन पई आमे जो सैंपल नौचे टाइम पीरियड भी नै गले कैलकुलेशन कर दिले हाफ ऑफ द सैंपल शुड बी टेकन इन द फर्स्ट 2 वीक्स एंड नेक्स्ट हाफ इन द रिमेनिंग 2 वीक्स रे नबा एवं समस्त जन को दायित्व देବାକୁ पड़िबो इधर फार्मासिस्ट नर्सिंग अफसर और हॉस्पिटल मैनेजर जे की कलेक्ट करिवे ई प्रेस्क्रिप्शन को तापरे स्टैंडर्डाइज फॉर्मेट कैन बी यूज्ड फॉर डाटा कलेक्शन एवं से कलेक्शन रो डाटा हमर गोटे गाइडलाइन अछि पर एबे गवर्नमेंट ऑफ इंडिया शेयर करछि प्रेस्क्रिप्शन ऑडिट पई सेतिरे एनेक्सर डी रे अछि फॉर्मेट केंति आपण माने डाटा कलेक्शन करिवे से विषय रे मु तार जस्ट एक एग्जांपल आपण को एठी देबी नेक्स्ट एटा होची क्राइटेरिया ओपीडी रजिस्ट्रेशन नंबर मेंशन हेछि ना नाही कंप्लीट नेम ऑफ द पेशेंट लिखा हेछि ना नाही एज जदी 5 वर्ष अधिक अछि लिखा हेछि इन केस ऑफ लेस देन 5 इयर्स मंथ रे लिखा हेछि नाही ओजन लिखा हेछि ना नाही दैट टू पुनी पेडियाट्रिक एज ग्रुप जदी अछि ताले सेथिरे आपनकर न्यूबॉर्न रे ग्राम्स रे लिखा हेछि ना नाही एवं पॉइंट रे लिखा हेछि ना नाही बड़ पिलांगर ए सब जिंस सेथिरे रहइबो then that date of consultation kebe hitla gender of the patient handwriting is legible or not brief history written or not allergy status mentioned or not ये सब कंपोनेंट्स रही 26 टा कंपोनेंट ये 26 टा कंपोनेंट ऊपर हमको एनालिसिस करय पड़िबो एवं से अनुसार हमें प्रेस्क्रिप्शन को ऑडिट करिया पई रेडी कर परिबा so these are all components जहा ऊपर हमें चेकलिस्ट तैयार करिकरी प्रेस्क्रिप्शन को केते पर्यंत लेजिबल अछि सेटा को हमें असेस करबा नेक्स्ट तापरे असला स्टेप 4 डाटा एनालिसिस एवं डाटा एनालिसिस बेल को हमको आ गोटे फॉर्मेट तैयारी करि पड़िबो एक्सेल शीट करिय पड़िबो एवं से एक्सेल शीट रे मेनली हमको यस नो जो जो कंपोनेंट 26 टा कंपोनेंट रहिला से कंपोनेंट रे यस नो रे ही हमें ताको आंसर लिखिबा एवं एक्सेल शीट रे से हिसाब रे यस रे 26 टा कंपोनेंट रे केतेटा यस आ केतेटा नो पड़िबो तादरे प्रति कंपोनेंट को हम असेस करबा एवं कंपोनेंट वाइज कोथरे परसेंटेज कम रहउची सेटा को देखा जिवो so that is the main another example mu say doji next eta dekhundu data analysis and calculation केमती करा जायछि P1 P5 माने प्रेस्क्रिप्शन 1 to 5 एवं एठी ओपीडी रजिस्ट्रेशन नंबर मेंशन हेछि ना नाही सबुथरे हेछि ताले यस पडला सो 100% प्रेस्क्रिप्शन रे आसीबो ओपीडी रजिस्ट्रेशन नंबर मेंशन कंप्लीट नेम ऑफ द पेशेंट इज रिटन और नॉट एथरे जदी गोटे नाही ताले से हिसाब रे परसेंटेज आसी जिवो यस यस नो यस सेमती एज कथा जेंति कहली सो ये क्राइटेरिया सब लिखा है से प्रेस्क्रिप्शन ऑडिट रे एवं से हिसाब रे हमें प्रेस्क्रिप्शन ऑडिट को एई फॉर्मेट रे पक्के करबा एवं फॉर्मेट अनुसार एनालिसिस मध्य कर परबा इट इज वेरी इजी टू एनालाइज द थिंग्स सेमती डाटा एनालिसिस करबा परे हमें परसेंटेज कैलकुलेशन करबा केते केते रु केते परसेंट ठीक अछि केते रु कोथरे कम परसेंटेज अछि केते कोट बेसी अछि अगेन क्वालिटी साइकिल को जदी हमें आसीबा पीडीसीए साइकिल अनुसार क्वालिटी प्रेस्क्रिप्शन ऑडिट को हम इंप्रूव करबा पई के रूट कॉज एनालिसिस करले तापरे डेवलप करे पई बाउंड टाइम बाउंड एक्शन प्लान करबा देन फाइंडिंग को शेयर करबा इंप्रूव करबा पई पीडीसीए साइकिल यूज करबा तापरे से इंप्रूवमेंट को केमती सस्टेन करबा एटा को हमें कर परबा सो फॉलो अप ऑडिट मध्ये हम कर परबा थरे हम जदी टेक अप करले एटा को गोटे डाटा कैप्चर करी करले प्रोजेक्ट हिसाब रे ताले टाइम लाइन परे इंप्रूव कला कि नाही केते इंप्रूव कला एवं आउ केते इंप्रूव कर परबो सेटा मध्ये हमें एनालिसिस करी तांगु देखे परबा सो दिस इज ऑल अबाउट प्रेस्क्रिप्शन ऑडिट मु आशा करी एटा बेसी बेनिफिटेड हबो फॉर द डीएमओ और सुपरिटेंडेंट मानकु एवं प्रेस्क्रिप्शन ठीक भाव रे हम केमती करे परबा ऑडिट करी रैशनल यूज ऑफ मेडिसिन्स करि परबा एवं प्रेस्क्रिप्शन ठीक भाव रे लिखै परबा दिस इज जस्ट एन गोटे ओवरव्यू मु सेति पे समस्त को धन्यवाद देबी जे आपण माने समस्त सुनिले एते समय तो नाउ टाइम फॉर क्वेश्चन आंसर बाबूजी डॉक्टर एनबी दास क्वेश्चन पचारथि बोधे
गोटे टॉपिक अछि ना डॉक्टर मीना सोमरो
हां मु आसी मैडम हां सर okay now Meena madam is there Meena madam can you talk in the next topic
good evening Thank you so much. I really appreciate the directorate and the leadership of Dr. Aditya sir for taking this forward and also to discuss on such an important topic. I respected ADCH, respected DFW, Dr. Bhuya sir, Dr. Ramkumar and Dr. Mishra sir. This topic of antibiotic resistance and antimicrobial policy is a very important area. As we proceed, as we progress, there is a increasing incidence of antimicrobial resistance or antibiotic resistance, what we are seeing across, not only in children, but also among adults. And infections occurring in the mother and neonates, they are exerting a substantial health burden. And antibiotics have been a miracle discovery. Antibiotics save lives. However, when the usage of antibiotics are not needed, we are using antibiotics when not needed, this is leading to the emergence of antibiotic resistance. And this is one of the biggest threats to global health. And this is leading to longer hospital stays, higher medical costs, more deaths, etc. So optimizing infection management is crucial for improving the individual outcomes. As the previous speakers have already highlighted, it is very important as to how is that we manage, we follow the standard treatment guidelines, what is to be done. It is not necessarily important that all babies in the SNCU should be receiving antibiotics. So these are important for reducing the incidence of antimicrobial resistance. And it is a group effort. All of us need to work together. It is not only the effort of only one person, the healthcare professionals, policymakers, all the stakeholders, starting from the support staff in the units, everybody has a role to play. And this improvement needs to be done not only in the SNCUs, but also in the labor rooms. So both the areas, we need to ensure that the BMW protocols are followed, hand washing and antisepsis techniques are well taken up. Fishbone analysis can be done for all the units, including labor rooms, followed by PDSA cycles. Earlier, Odisha had a good practice of taking up small POCI projects. So this is something which we can again start as a key activity, quality assurance. Each of the SNCUs can actually take up some of these POCI projects, and one of the topics could be to reduce the antibiotic usage. UNICEF will continue to provide technical supports towards the improvement of quality care for the newborn and also for newer initiatives like the MNCUs, the mother newborn units, and also strengthening the KMC, IKMC, and all of the new initiatives. I again appreciate and thank the role of the department in taking up these initiatives and taking the leadership for ensuring not only survival but also intact survival, because we are not only talking of survival alone. Though Odisha has a high newborn mortality rate, we are talking of intact survival, and we should address the other important areas like birth asphyxia. So thank you so much for giving this opportunity and also taking forward these initiatives of improving the capacities of the staff. Thank you. Thank you so much.
अच्छा मधुस्मिता मैडम रेज हैंड करूतले किछि कहिबे कि आपण जदि कहिबे हम आपन अलाउ कर दउ नाले क्वेश्चन आंसर सेशन रे किछि लेखन चार्ट रे if you are not raising hand accidentally. भुया सर कोन कहबे कि आपण भी रेज करछन हैंड
हाँ मुझे पचार थे आपन को
सर कोन
एक्चुअली जो टॉपिक मु प्रेजेंटेशन कली एक्चुअली मेनी ऑफ द आंसर्स आई गॉट फ्रॉम योर टॉक एक्चुअली
सर
so what you presented is actually is it being done in our state, this audit of prescription?
This
Has it
is
started?
It's a guideline I have shared from Government of India.
Oh, it has not started. If it can be started actually in a real sense, it will go a long way in improving the rational prescription and legibility of prescription.
Actually, sir, we are doing many quality improvement activities in the facility, like Kayakalpa, Muskan, Lakshya programs. They have got many checklists, and in those checklists, one of the component is prescription audit. If they have done prescription audit, then they will get 2 marks. If they will not get, they have not done any prescription audit, then they will get 0 marks. So
this can be compiled and presented, no? Like yes. I quoted the ICMR study. when they have made a prescription audit and found out. Similarly, if we can make a prescription audit and present a presentation after 1 year, actually you know what is happening in our state. Actually.
This is something, sir, internal quality improvement. On their own, they can do it. But externally also, somebody can do. Suppose IAP, Indian Academy of Pediatrics, wants to do prescription audit, they can apply to the mission director and clear the ethical committee, and you will also be allowed for the prescription audit for few districts or few facilities. That can be possible.
No,
But
this audit should involve all specialties of medicine, and whatever you presented, the steps you presented, that involves everybody actually. At government level, this can be done.
yes, sir.
The results can be found out actually.
Thank you, sir. Dharmangad, SDS Dharmangad. Dharmangad, SDS, do you want to say anything? No. Okay, so we don't have any more questions. One question was there from NB Das. I have answered it. Actually, CRP 10 milligram per liter or 1 milligram per deciliter. Second thing is about how to clean mobile. It is better that mobile companies can tell how to clean mobile, but we can restrict our mobile entry into the critical care units.
Sir, actually mobiles actually amaro jo transparent covid time re sir amaro gote se jo ziploc bags ase sir, ziploc bags pete rakhanti and they are disposable, so they can be kept. And one, and number two sir, tar gote spray aschi sir, spray clean kariya pai seta can be used.
Yes.
Gote spray achi sir, electronics pai.
Another question is there from GPS Mishra. Amoxicillin doses for more than 7 days baby 30 milligram per dose or per day for pneumonia treatment.
Sir, IMNCI हिसाब रे 0 to 7 days पर्यंत तो सेटा तो नहीं, 7 days to 2 months पर्यंत it is 30 mg per kg per dose BD for 7 days. एटा होची निमोनिया पई एटा डोज टा IMNCI रे दिया अछि. आउ अन्य कॉजेस रे किंबा 2 months रो 5 years रे जो डोज टा अछि सेटा 25 mg per kg per dose BD for 5 days.
Yes, sir. GPSY, you can go through the SANS guideline which was supplied by Government of India. I think it was shared with all the districts. So you should have this guideline in your OPD, and if you will go through that, you will get your answer. That is correct from Ram Kumar sir. Next is respiration rate more than 60 per minute. It is pneumonia. Is it pneumonia?
Respiratory rate more than 60 if especially less than 2 months thore hella pare second time you have to count and the second count is final. If it is more than 60 for community level it is classified as pneumonia in the absence of severe chest indrawing. But if it is less than 7 days, any tachypnea more than 60, then it indicates whether it is a possible serious bacterial infection or it is a very severe disease. Seti kichi pneumonia or term nahi, less than 7 days. So because this guideline is being issued for the IMNCI, seti tarko pai a terminology use करायची. So if at all there is a point that probably more than 7 days baby more than 60 है ना IMNC हिसाब रे pneumonia ले classify करायची baby टार pneumonia ने heart disease ही पारे. So yes possibly. So more than 60 हे गला तार अन्यतम आउ किछि sign आसी जेथिबो किंबा हमें जदी 48 hours भितर हमें ताकू जो डाकुचो even if the baby is not improving we will call in 48 hours as per the program. So or earlier if other danger signs appear. So हमको आउ किछि आसिला ताहले ताकू आउ किछि इन्फेक्शन कोन भाबे कि हमें एंटीबायोटिक दे के हमें रेफर कर दे परिबा जोठी जीवो सेठी तांकर कंप्लीट इवैल्यूएशन होबो as per the program.
Yes, thank you. Actually, it is intimate माने समस्त जणाइବାକୁ चाहूची आमे pneumonia possible serious bacterial infection even if within less than 2 months रे जदि आमे पाउचे जहा भी रामकुमार सर देखेले any sign आपण पाउचंती ताकू आपण possible serious bacterial infection हिसाब रे रिपोर्ट कर परिबे किछि असुविधा नै किंतु provided you have to count the respiration for 1 minute not that 15 second count करी 4 रे गुणिले. Another question is there, in spite of so many improvement in neonatal care, what are most common neonatal death causes in our state? Actually, again, it varies from causes to causes. Agur jodi ame dekhiba, sepsis was common cause. Bartaman birth asphyxia is most common cause, which is preventable also. Tenu bartaman ame SNC ro data ku dekhi analysis kari jani paruchu je amar koti na koti ame gap mane kiछि gap rohuchi amar service provision re. Because on an average nationally ame dekhilu 18 ru 19% birth asphyxia admission in SNCU, whereas amara 25 ru 30% hoji on an average, kintu district wise je dekhiba 40% admission madhya hochi. So ethi labor room ro gap rohichi, labor room ro confidence building houni staff manakar jaha phalare ki birth asphyxia adhika asuchi. So now this is the high time to think about that. Ebe recently Tamil Nadu ro presentation houtla जो थ्री की एसएनसीयू एडमिशन होचंदी मोर देन 90% आर प्री टर्म एंड एलबीडब्ल्यू बेबीज तो सेप्सिस आ बर्थ एस्फिक्सिया पूरा कम तांकर तेनु से को हमको आखिया रखियो पड़िबो ए जो इन्फेक्शन प्रिवेंशन कथा कहला इट इज आल्सो एप्लीकेबल फॉर लेबर रूम आल्सो एप्लीकेबल फॉर द पोस्टनाटल वार्ड इफ यू वांट we want to prevent sepsis and birth asphyxia. So birth asphyxia तो confidence building of the nursing officers in labor room is a must. सेटा जदि करिवा ताला हमर बाथा शिक्षा रो एडमिशन भी कमी जो प्रिवेंशन कर करबा. So I think there is no more question. Panelist को बहुत धन्यवाद. सर आप किछि ऐड करिवे विजय सर?
हाँ एक्चुअली बहुत भला हला. इट इज ए वेरी वेल ऑर्गेनाइज्ड and it has gone without flaw and every teaching is a learning experience for everybody who are present. So such programs should be there in future to do mass education of people involved in the care of the newborn babies for better newborn survival and intact survival. Very important and valid points have been told by all the speakers, and Ramkumar has told excellent, and he has touched all practical aspects of this use of antibiotics in newborn. He has told very well, and Meena madam has also summarized everything in a very nice way, and Dr. Bhuya has also highlighted the importance of prescription audit, and you are the right person to start the program of prescription audit in our state. So I think you yourself with UNICEF should take up the project. I remember 25 years back, I presented a paper on prescription audit from a tertiary care hospital in the East Zone conference, and it created a lot of highlights and sensation among all, like Bhuya sir depicted today. So there is a need for prescription audit and correcting our own mistakes, which is done at our level.
Yes, very nice.
रामकुमार किछि कहबे?
Vedichan sir, thank you sir for the kind words.
What is the definition of birth asphyxia practically? Practically is if the baby is not crying after birth. That is simple. No, there is no complicated definition. Meena madam, any final conclusion?
So jodi jodi se jo birth asphyxia कहउचंती, what is the definition of birth asphyxia? So birth asphyxia is actually inability to initiate spontaneous breathing at birth is called as birth asphyxia. तो एटा होची हमरो माने definition गोटे, but as and जेमती जेमती हमरो level बढ़िबो तारो definitely blood gas sangre cord blood sangre बहुत किछि definitions अछि for the different studies pai seta include hobo. The only one thing, one message to be given is that there is an entity called as perinatal depression. So pilata due to some reason baby is initiate kala pare kimba initiate karnatyo take samay pai for few hours baby will be very looking very sick, but after that baby completely recovers and the baby has no other signs of HI. So this entity is called as perinatal depression and it needs to be differentiated from HI because perinatal depression ro prognosis otherwise is much better compared to the other serious forms of HI.
डॉक्टर आचार्य का क्वेश्चन हला मैट्रेस रे कोना हाले सेटा किंती इन्फेक्शन होबनी हबो तेनु मैट्रेस को किंती हमें पैच करबा तार व्यवस्था मध्ये करा जायछि सो हॉस्पिटल मैनेजर शुड टेक द इनिशिएटिव एवं हाउ टू रिपेयर दोज मैट्रेसेस. ओके मीना मैडम फाइनल वर्ड. Okay. So I think this is the time to close this session. हम बहुत धन्यवाद देवी प्रभाकर सर को, विजय सर को एवं रामकुमार सर को पर नाइस डेलिब्रेशन एवं
मोर मेबी जे टॉप रे अछि सरिले
आपण माने एक्सप्लेन कर परले एवं आगो को मध्ये हम भाबु जे एवली सेशन रखिबा एवरी मंथ हम एट लीस्ट गोटे रखिबा 2 घंटा पई जे फल कि हमर सर्विस प्रोवाइडर माने बेनिफिटेड हेबे एवं समस्त को धन्यवाद एवं नमस्कार. आमे एबे लीव करछु. थैंक यू.
Thank you.